In the next image, I have shown a quick revision for nephrotic syndrome. You can notice this child having a very characteristic periorbital edema, which is the earliest presentation. And second, I have made you remember that foamy urine is again a feature of proteinuria. So for a patient who's having nephrotic syndrome, especially a child, it would be minimal chain disease. Minimal chain disease is associated with usage of NSAIDs. That's the MCQ to be remembered. Overall, the most common cause of minimal chain disease is obviously idiopathic. That I'm not asking you to remember. I'm saying the drug with which this has to be remembered is non-steroidal anti-inflammatory drugs, NSAIDs, and food process effacement would be seen. Minimal chain disease is also called as selective proteinuria because low molecular weight proteins would be lost in this particular case, and there would be a diurnal variation of the edema, with edema starting from eyes, then go to genitals, and then to the feet of the patient. You can go in for a spot urinary albumin creatinine ratio in the patient, or you can check for 24-hour urinary proteins in the patient. Obviously, the 24-hour urinary protein in this case has to be more than 3.5 grams. Because the main treatment for this condition would be prednisolone for 8 weeks, so this condition will also be called as steroid responsive nephrotic syndrome. In most of the cases, the patient will develop steroid dependent nephrotic syndrome. If a patient develops steroid dependent nephrotic syndrome, then the management for this particular condition is obviously steroids only. But if he says steroid dependent nephrotic syndrome with features of steroid toxicity, then due to the development of steroid toxicity, the manifestations that will appear in the patient will be that of weight gain, hirsutism, proximal myopathy. Then you will have to start the patient on an alternative immunosuppressive drug by the name of cyclophosphamide, which is the main treatment for the patient. However, if a patient is having steroid resistant nephrotic syndrome, for steroid resistance, the drug to be used in the patient is cyclosporin. So for management of these patients, these are the alternative molecules which are to be remembered by you. Minimal chain disease is a leading cause in children, but when it comes to adults, the important cause of nephrotic syndrome will be focal segmental glomerulosclerosis. The features of focal segmental glomerulosclerosis that would be different over the routine case would be there would be hypertension in the patient because there is a glomerulosclerosis. One of the leading causes of focal segmental glomerulosclerosis is obviously idiopathic, but then for the secondary variety, you need to remember HIV and human parvovirus B19. Then you need to remember drugs which are responsible for causing focal segmental glomerulosclerosis, which could be in the form of one street drug, that is heroin, and second can be a bisphosphonate by the name of pamidronate. One of the histopathological findings for focal segmental glomerulosclerosis to be remembered would be changes in the food processes. Remember the fact that food process detachment or food process vacuolization are the terms to be remembered in this case. Please remember that food process effacement is a feature of minimal chain disease, but detachment and vacuolization is a feature of focal segmental glomerulosclerosis. For management of these patients, the drug to be used is cyclophosphamide. But if he says how do you manage the high blood pressure of the patient, the hypertension component of the patient will be managed by ACE inhibitors. For diuretic purposes, you will be using spironolactone because there's a weight gain and edema in the patient. So we are having a specialized drug for each of the problems of the patient, but obviously for the immunomodulation that is required, cyclophosphamide would be given. Then for geriatric population, if he says what is the leading cause of nephrotic syndrome, it is membranous glomerulopathy, that is MGN. Please remember the fact that when it comes to MGN in a patient, membranous glomerulopathy, important cause for that is to be remembered for especially the primary variety is antibody to phospholipase A2 receptor, that is anti-PLA2 receptor, and this antibody is very characteristic, and if this is positive, then you don't even need to go for a biopsy. For the secondary membranous glomerulopathy, one of the important viruses responsible is hepatitis B, then is hepatitis C. Then for drugs, you need to remember drugs like captopril, D-penicillamine. D-penicillamine is a chelator that is given to manage these patients. Then also remember the fact that membranous glomerulopathy is associated with solid organ tumors. In fact, if he says which is the most common variety of nephrotic syndrome seen with tumors, then it is membranous glomerulopathy. Solid organ tumors could be like renal cell cancer. Solid organ tumor can be like, for example, I can say prostate cancer. And then which nephrotic syndrome is associated with autoimmune disorders like Hashimoto's thyroiditis or Graves' disease or dermatomyositis or SLE. Then with autoimmunity also, the nephrotic syndrome that is associated is MGN, that is membranous glomerulopathy. So these are some of the causes for MGN to be remembered. And as far as the histopathological finding of this is concerned, you would specially be having a finding of especially electron microscopy finding to be remembered for this condition would be that of subepithelial deposits with spikes. You will come across subepithelial deposits even in patients who are having post-streptococcal glomerulonephritis immune complex deposition, but with spikes is a feature that is seen with MGN, and then specialized treatment can be given. For treatment of these patients, the molecule to be used would be one cyclophosphamide. This is an immunomodulator that would be useful for this patient. And in fact, what I will do is that I'll be giving alternative month immunosuppressive therapy for the patient, where cyclophosphamide and prednisolone will be used in alternative months for this for the management of this patient, like 1 month cyclophosphamide, 1 month prednisolone for the patient. Along with this, for the edema component, which could be the pedal edema components, spironolactone will be used in this particular case. And then for the hypertension component of the patient, we can be using ACE inhibitors, or we can be using angiotensin receptor blocker in the patient. And last but not the least, for these patients, you also have to remember that the amount of protein intake is directly proportional to the GFR. I mean, if the GFR is low, I'll calculate the GFR on the basis of the CKD EPI formula or MDRD formula, and depending on the values, then I will proportionately manage the patient. If the GFR is low, you have to reduce the protein intake by that amount, because if you give normal amount of protein, then it will cause more urea, and urea which is not excreted by the kidney is definitely not a very welcome finding. For the pediatric part, I can just mention the Finnish variety of the nephrotic syndrome. For the Finnish variety of nephrotic syndrome in a patient, which is encountered in newborn children, you would be having a NPHS1 and a NPHS2 gene. NPHS1 gene is related to nephrin, NPHS2 is related to podocin. So they form a zipper mechanism in the kidney. The basement membrane of the kidney is affected, so there is definitely a proteinuria. So the clinical presentation of Finnish variety of nephrotic syndrome would be a presentation of non-immunogenic hydrops fetalis. You know that the RH incompatibility is a feature of, or is responsible for development of immunogenic hydros fetalis, whereas Finnish variety causes a non-immunogenic hydros fetalis in a patient. So these are some important causes of nephrotic syndrome that are to be remembered by you for questions. Coming to the next slide, guys, this is an immunofluorescence study which is showing a very characteristic granular appearance. You can notice the subepithelial deposits in electron microscopy. The slide that I have shown here before you is characteristic of MGN, which is encountered in geriatric population. And the main feature why you can pick up membranous glomerulopathy is one, because of the granular appearance of the basement membrane. Second, you can notice red blood cells inside. Normally, RBCs are not a feature of nephrotic, but in MGN you have a mixed picture of nephrotic, nephritic. So RBCs are hugging each other. And then you can notice in the electron microscopy these subepithelial deposits which are having a spiky pattern. You can see all the subepithelial deposits. These are the subepithelial deposits that I'm talking about. These are all immunologically mediated in the patient. So due to combination of granular deposit, then subepithelial deposits with a spike pattern and RBCs inside the glomerulus, the final diagnosis of the patient would be MGN, and even the history can be given, especially for an adult patient, so you anyway know that this is not a minimal chain disease. Okay guys, coming to the next slide, what we are gonna do here is quickly revise aspects related to post-streptococcal glomerulonephritis. From this image, I think you can immediately recognize the very characteristic starry sky appearance, which would be encountered in patients who are suffering from post-streptococcal glomerulonephritis. We also come across starry sky appearance on our ultrasound liver, and that would be a feature that is encountered with respect to patients having acute viral hepatitis. But when it comes to a starry sky appearance with respect to a CT head then or a MRI head, then we know it is neurocysticercosis. And with respect to a kidney biopsy specimen, we very well know that this would be immunofluorescence study with respect to PSGN in the patient. Now, as far as post-streptococcal glomerulonephritis manifestations are concerned, it is an example of type 3 hypersensitivity reaction because this is an immune complex mediated nephritis in a patient. The highlight of the disease would be that there would be damage to the glomerulus, which will result in a very classical presentation that would be hematuria. You would be remembering the fact that the bacteria, the group A beta hemolytic streptococcus, would be having nephritogenous strains. And what I mean by nephritogenous strains is that there would be antigens present on the surface of that, and the antigens would be called as SPEB. What I mean by the word SPEB would be that there would be a streptococcal pyrogenic exotoxin B. This streptococcal pyrogenic exotoxin B is the main reason why we are going to call it a presentation of nephritogenous strain. This predisposes to development or damage to the kidney. Now let us see what will be the profile of the patient. The standard presentation will be that of a hematuria with hypertension, and there is a subnephrotic proteinuria. Most of the time he might describe a child or an adult with hypertension, and the BP might become so high that the patient might go into crisis. This can either result in development of hypertensive encephalopathy, where the person will become unconscious due to high blood pressure, or it can even contribute to left ventricular failure in a patient. So in case a patient is having a hypertensive crisis and ends up with encephalopathy, then you will have to use obviously aggressive drugs or parenteral drugs to control the blood pressure. In the workup of this patient, one of the highlights would be a low C3, but the point is that C3 can be low even in nephrotic syndrome patients because C3 can be lost in the urine also. So you will have to rely on findings like RBC casts which are present in the patient. Then you will have to rely on dysmorphic RBC. In fact, I want you to remember that change in the shape of the RBC is very characteristic for glomerulonephritis. So dysmorphic RBC signify the fact that there is a glomerular bleed occurring in a patient. The antibody that you're gonna use in this condition is not gonna be ASO. The antibody in this case is anti-hyaluronidase antibody. This is a very specific antibody for the group A beta hemolytic streptococcus with respect to PSGN. Another antibody is anti-DNase antibody. Remember my statement, do not answer ASO because ASO is characteristic for rheumatic fever, and because the GFR of the patient is low, so if you calculate the GFR by any online calculator like CKD, EPI formula or Cochrane World formula, GFR of this patient or estimated GFR will be less. So what you're gonna do next in the management of this patient is that you will suggest a biopsy. And when you subject a biopsy in this patient on light microscopy, the highlight of the disease would be there would be a hypercellular glomerulus in the patient. There would be infiltrates into the glomerulus of the patient, and when you are gonna check the patient by electron microscopy, then the special finding of electron microscopy in this particular case would be that there would be subepithelial deposits. Now, because subepithelial deposits have been discussed even in the previous slide with respect to patients who are having a presence of membranous glomerulopathy, though there are spikes present there as well. So there could be some kind of error or judgment on the part of the pathologist. That is why we were talking about this slide where there would be a very characteristic starry sky appearance or immune complex deposition scattered all over the glomerulus of the patient, which is useful for diagnosis. For management of this particular case, you will have to use the following strategy. One of the primary things to be done for these patients is control of high blood pressure. The hypertensive crisis or the encephalopathy of the patient can be managed with sodium nitroprusside. Then, apart from the crisis component, another thing to be taken care of is the heart failure. If that occurs, I'm saying if it occurs, LMNOP, you know that Lasix, morphine, nitroglycerin oxygen positioning is used for management of left ventricular failure in a patient. A single shot of benzathine penicillin is also recommended for these patients. The advantage of this single shot of benzathine penicillin to the patient would be that when you give this shot to the patient, it would help in eliminating the infection which was present in the patient. Remember that the same shots of benzathine penicillin were used in rheumatic fever also, but they were given 3 weekly for prophylaxis of recurrent sore throats. But when it comes to post-streptococcal glomerulonephritis, it is mostly a single dose. Benzathine penicillin has also been asked for the following situations, that is it is the drug of choice. If I just say BP single dose, that is 2.4 million units single dose would be useful for treatment of primary syphilis. Then they have also asked about the usage of benzathine penicillin, that is 3 shots on a weekly basis, like this week, next week and the next week. 3 shots weekly have been asked for cardiovascular syphilis, where the gamma would be damaging the aorta, causing a aortic aneurysm formation. And last but not the least, benzathine penicillin would also be used in patients. And last but not the least, crystalline penicillin G, that is penicillin G plain, that would be given intravenously for 2 weeks for management of patients of neurosyphilis. The best test for diagnosis of neurosyphilis is CSF VDRL. When it comes to this data, the second one that I mentioned in the inferior part, these are some questions which have been asked with respect to benzathine penicillin usages. Otherwise, for management of PSGN, it is conservative management. And I can say one more fact, that if the patient is having uremia, then hemodialysis is obviously to be recommended. Hemodialysis should ideally be done whenever patient develops uremic manifestations. Remember, one of the absolute indications for hemodialysis is uremic pericarditis. Even in a multiple choice question, if you are having uremic encephalopathy in the choices and uremic pericarditis in the choices, the absolute indication that you are supposed to answer in the MCQ for patients who are having a requirement of hemodialysis is uremic pericarditis. Though uremic melena or uremic fast would be present, but this is an absolute indication per se. Moving ahead, you can see a patient connected to a dialysis machine. So here what you need to remember is that for performance of dialysis in the patient, we shall be using a fistula that is called as seminobrestia fistula. Seminobrestia fistula would be connecting the radial artery of the patient to the cephalic vein, and the advantage of this would be that once you connect the artery to the vein of the patient, the hemodialysis process will become smooth, in a sense that the principle behind the connection of the two is that there will be a change in the internal lining of the vein and there will be a arterialization of the vein. Now, why do I want to achieve arterialization of the vein of the patient is because of the fact that there is a change in the internal lining of the vein. This is going to reduce the chances of thrombophlebitis per se, because every time you cannulate a vein, there is a thrombophlebitis. So if I have to do hemodialysis 3 times per week, you all know that hemodialysis is done 3 times per week and every session is 4 hourly. If you have to do a new cannulation every time, gradually all the veins in the body will suffer thrombophlebitis. I don't want that to happen, and I can't afford that to happen because it's horribly painful. No, I mean, thrombophlebitis is occurring every time at a new site. So I am creating a permanent site for hemodialysis. The permanent site for hemodialysis is at the junction of the radial artery and the cephalic vein of the patient. That is what I'm talking about. A seminobrestia fistula is the one that would be used in this case, so that you can use the same site again and again and again. So advantage of this would be that there would be a reduction in the incidence of thrombophlebitis of the vein, secondary to which we can use the same site again and again. The frequency of doing hemodialysis is 3 times per week. Every session of hemodialysis will be for approximately 4 hours. One of the biggest complications of hemodialysis to be remembered by you is hypotension. He says, what is the biggest complication of recurrent hemodialysis? Then the most common complication of recurrent hemodialysis should be remembered as accelerated atherosclerosis. Please remember the fact that atherosclerosis will increase the cardiovascular mortality. So what I want you to remember is that hemodialysis process is less preferred over a transplantation per se, since the chances of accelerated atherosclerosis will increase. Another complication of recurrent hemodialysis that is worth remembering for MCQs is dialysis dementia. There are two reasons for dialysis dementia. One is the presence of aluminum in the dialyzer fluid. Now, with improvement in technology, the aluminum in the dialyzer has become relatively lesser. So, though this is given in books and older MCQs, I've just discussed that with you. The major reason for dialysis dementia would obviously be deposition of A-beta-2 amyloid, and this A-beta-2 amyloid deposition will predispose to development of dialysis dementia. In fact, carpal tunnel syndrome that develops is also because of A-beta-2 amyloid deposition. Remember my next statement, A-beta amyloid deposition is seen in patients of Alzheimer's disease. So one, you need to remember the closely matching terminology that I have highlighted before you. A-beta amyloid for Alzheimer and A-beta-2 for dialysis dementia in the patient. And hemodialysis, the absolute indication is obviously uremic pericarditis followed by uremic encephalopathy in a patient. Coming to the next slide, what you can see is that we have now planned to do a kidney transplantation in the patient. One of the most important indications for kidney transplantation is diabetic nephropathy. The site where you will put the kidney transplantation will be in the right iliac fossa. So when it comes to the donor kidney, the kidney that is selected from the donor will be the left kidney of the patient, because this would be having a longer renal vein, so the chances of anastomosis would be relatively better from the surgeon's perspective. But in the recipient, the new kidney is not put in the place of the old one. In the recipient, the kidney is put in the right iliac fossa. As you can see, we have placed the new kidney in the RIF of the patient. Why is the new kidney put in the right iliac fossa? Because if this kidney will get rejected, it will be easy for you to remove the kidney and deploy a new one. You see, normal traditional location of kidneys is retroperitoneal. The kidneys will be present very posteriorly. So here what we need to do is simply the fact that we need to place the kidneys in the right iliac fossa. In case they get rejected, you are definitely in a position to remove them, because traditional sites would have been horrible one to actually taken care of. So we preserve the old kidneys in all cases except one. Autosomal dominant polycystic kidney disease. In ADPKD, we will always go in for nephrectomy in the patient with a new kidney in place, that is in the right iliac fossa. But nephrectomy, because in the old kidneys they're horribly painful. Here there is no pain in like diabetic nephropathy, no pain. So we preserve the old kidneys and the new one is placed in the right iliac fossa of the patient. And there can obviously be chances of rejection that could be hyperacute rejection, acute and chronic rejection. Hyperacute rejection will usually occur within minutes, because the moment you are gonna establish the vascular anastomosis between the donor and the recipient, the new kidney will definitely fail. But when it comes to acute rejection of the kidney, in those circumstances, it is an example of type 4 hypersensitivity reaction. Remember my words, and it will occur within weeks to months, that is within 6 months. It is not 4 weeks, it is weeks to months onwards. And when it comes to chronic rejection, it will obviously occur after 6 months. So the rejection of the kidney is within minutes, then within the first 6 months, then after the 6 months of the patient. So there are 3 aspects to be remembered. Remember the fact that the hypersensitivity reaction of hyperacute kidney rejection is type 2 hypersensitivity, acute will be type 4 hypersensitivity, and chronic will also be type 4. So remember 244. I know the controversy is 234 guys, just follow what I'm saying. 244, that's the most researched data that I would say, that for hyperacute is 2 understandable, and then for acute is type 4, and chronic nobody will dispute because it's a delayed hypersensitivity, na? But when it comes to acute, it occurs with respect to the fact that it will occur in the first 6 months. So this is an example of type 4 hypersensitivity reaction in a patient. Then there can obviously be a possibility of opportunistic infections, because you're putting the patient on anti-rejection drugs, and these anti-rejection drugs that you use in the patient are cyclosporin, azathioprine and prednisolone. C stands for cyclosporin, A stands for azathioprine, and P stands for prednisolone in the patient. These are the standard drugs that we will be starting in all patients, along with counseling regarding barrier nursing. Remember the fact that the backup drugs that you have at your disposal are sirolimus, and another one that is available at your disposal is everolimus. When it comes to sirolimus and everolimus in a patient, they are mTOR inhibitors, that is mammalian target of rapamycin inhibitors. The good thing about these molecules is that especially sirolimus is a non-nephrotoxic molecule. So normally all the anti-rejection drugs are gonna be nephrotoxic molecules, and obviously the toxicity of them can cause the kidney to fail. But sirolimus is a silver lining of the cloud, I would say, that you basically need to remember. Now, because I said that anti-rejection drugs can contribute to development of opportunistic infections after a kidney transplantation, so this is obviously a must-know for you, that you need to remember the presence of opportunistic infections that are encountered in patients after post-kidney transplantation. One of the opportunistic infections that occurs in the very first month after surgery would be wound infection. And this wound infection would be MRSA, that is methicillin resistant Staph aureus, MRSA. This is, I would say, a disaster because the patient spends so much of money and resources and everything, and then he deteriorates. So it really doesn't make sense. And then can be a reactivation of a virus by the name of herpes simplex, and then can be reactivation of herpes zoster. Between 1 to 6 months of age, one of the common opportunistic infections is pneumocystis jirovecii, and after jirovecii, the next one to be remembered by you would be cytomegalovirus. If they ask you to select the virus per se, then the answer is obviously cytomegalovirus. Otherwise, the overall answer is jirovecii, which is a fungus. After 6 months of kidney transplantation, the organism to be responsible is Aspergillus. The fungus to be remembered here is Aspergillus, but the virus to be remembered is polyoma virus. Polyoma virus would be BK virus. I want to remind you the fact that there is also polyoma virus by the name of GC virus, which causes a disease which is asked in MCQs, PML, progressive multifocal leukoencephalopathy in a patient. PML or progressive multifocal leukoencephalopathy is caused by JC virus, whereas polyoma virus would be responsible for a post-kidney transplant opportunistic infection. Hepatitis B and hepatitis C are common. Both of these are common infections, both B and C, but then difference is obviously cytomegalovirus and a polyoma virus in a patient. So this is an important slide that I wanted to remember for the opportunistic infections perspective. Now, if the question begins by saying that what is the leading cause of post-transplantation lymphoma, then obviously the answer is not to be given from any of the statements or the viruses given on the top. Post-transplantation lymphoma is Epstein-Barr virus. But if he says the fact that what is the leading cause of a graft failure after a solid organ transplantation, I mean, he may not use the word kidney transplantation, he might just say what is the leading cause of graft failure which is encountered after a SOT, that is a solid organ transplantation, that would be answered by you as cytomegalovirus. However, if he says that what is the leading cause of graft failure after hemopoietic stem cell transplantation, that is bone marrow transplantation, the answer is again cytomegalovirus. That is why we usually give prophylaxis with ganciclovir, so that we can minimize the risk of development of this graft failure. Otherwise, it's a disaster situation, as I said, that after all the hard work that you've done, you lose the patient for something as simple as infection which could have been effectively managed. Once we have revised the aspects related to this, then we'll look at two simple slides. In one, I have shown before you a very classical. This is called as drooping water lily sign. In the earlier part, I have talked about a floating water lily, that is hydrated cyst. But now drooping water lily sign is a feature that is seen with respect to duplication of the collecting system of the kidney. So a easy pick. I think you would have read it in other subjects also, but since I have come across this question, a quick revision. A duplication of the collecting duct or the collecting system of the kidney is responsible for this drooping water lily sign. On the other hand, if you look at this image, which is very surprising, they just gave an image like this, and one of the choices was womb stone, that is gonna be a calcified fibroid, which is unlikely to be this big. No, I mean this big womb stone, very unlikely, because it would be in the wall of the uterus, and uterus in a postmenopausal lady becomes smaller. So this is not to be answered as a womb stone. The answer for this would be given by you as a presence of a giant bladder stone, and the bladder stone can be of two varieties. Either it can be primary or it could be secondary. What I mean by a primary bladder stone is that it is developed in the bladder itself, or secondary could be coming up from the top. But this characteristic image of a shadow bang in the middle of the pelvis would be that of a calcified bladder stone. Coming to the next slide, we need to remember classification of chronic kidney disease using glomerular filtration rate and albumin creatinine ratio. Well, first and foremost, guys, you need to remember that instead of using the word stage, he started using the word grade. So, well, there's a slight change of terminology with respect to G1, G2, G3 instead of stage 1, 2, 3. Now, when it comes to stage 3, the word used for 30 to 59 ml per minute now is decreasing it in multiples of 15. That is, it is 30 to 44. And then is going to be 45 to 59. So the increase here is in multiples of 15. Coming to the next slide, we will talk about classification of chronic kidney disease using glomerular filtration rate and ACR, that is albumin creatinine ratio. First and foremost, I want you to remember that instead of using the word stage, he has used the word grade. Now, the point to be understood is that earlier when it comes to stage, they were using a cutoff of 30 to 59 ml. But now instead of using this cutoff of 30 to 59 ml, they've just subdivided this into a 15 cutoff value. So let's try to remember it. More than 90 is obviously grade 1. 60 to 89 is a downgrade of about a range of 30 ml per minute. But then the decrease which is occurring is in the range of 15 ml per minute in all the values. So even if you don't remember the mathematics here, you just have to downgrade from 90 to a value of less than 15 in multiples of 15 itself. That is, from 60 you downgrade to 45, then from 45 you downgrade to 30, like that. So there are 4 jumps of 15, 15 and 1 jump of 30 that you need to remember. When it comes to the grades, G3 has been subdivided into G3A and G3B. Otherwise, as such, the data is the same. I mean, the cutoff for GFR is still the same. CKD is defined as GKD less than 60 for a duration of 3 consecutive months. Albumin creatinine ratio. Instead of calculating 24-hour urine, because like in India, patient might say, I'm not comfortable collecting urine. How will I keep it in my house? There's a temple in my house. He might say things like, or practical, you know, he may under collect or over collect. He may not collect the morning sample or the next day. So the advantage of spot urine sample is that you can be checking the urine albumin and urine creatinine. And by checking the urine albumin and the urine creatinine of the patient, you will be able to get a report. If it is less than 30 milligram per gram of creatinine, we call it A1. If it is 30 to 300 milligram per gram, then you are going to call it A2. And if it is more than 300 milligram per gram, you're going to call it a A3, though the units can range from, let me say, milligram per micromoles also. Once you graded this into A1, A2, A3, you just need to read or write values like patient is having G4, A3, which means the fact that the damage is more extreme and that is GFR of the patient is less than 30 and there is a severe proteinuria also. From the exam perspective, remember G1, A1 does not indicate any significant kidney damage and G2, A1 also does not indicate any significant damage. I mean, when it comes to these two values, there is no CKD in the absence of markers of kidney damage. What I mean by markers is you can be using KIM1 or NGAL or cystatin C. And as such, per se, these two values are, I would say, the green zone and do not indicate any significant damage. But when it comes to the remaining values, they obviously indicate that the damage in the kidney parenchyma of the patient is increasing. One of the leading cases of chronic kidney disease is diabetic nephropathy. Diabetic nephropathy will obviously be having proteinuria and the GFR of the patient will be reduced. If the GFR goes less than 30, it's a time for decision making, either transplantation or dialysis in the patient. For screening for diabetic nephropathy, if he says, then the answer is urinary albumin creatinine ratio, UAC, or instead of saying that, you can say albumin creatinine ratio. But the basic point is that screening test is UAC. If you demonstrate presence of albuminuria, which is in the range of 30 to 300 milligram of albumin per gram of creatinine, it means that the patient's kidneys are already damaged. And because the kidneys are damaged, patient, when you tell him, he might laugh on you and say, sir, you were telling me my kidneys are damaged, I got my creatinine done, it was normal, and you tell me my kidneys are damaged. So I'll tell him, buddy, serum creatinine is the most specific test for kidney damage. The most specific kidney function test, or the most accurate kidney function test, is obviously serum creatinine. But the point of mine is that serum creatinine is gonna take some time to rise. It is specific, it is not sensitive, so therefore it is a good test, but it does not tell me whether the kidneys have been hampered right now or not. So it's a good idea to start the patient on ACE inhibitors and angiotensin receptor blockers. The bottom line is serum creatinine can be taking some time to rise, and I don't want to take a chance, so that's why I'm using ACE inhibitors for management of this patient. Okay guys, coming to the next slide, we need to remember aspects related to acute kidney injury development in a patient. All they have done in the KDIGO criteria is that they've just used the names stage 1, stage 2, stage 3, otherwise everything else is same. That is 1.5 times of normal serum creatinine, doubling of serum creatinine, and 3 times elevation of serum creatinine. Even the urine output cutoffs are the same, that is 0.5 ml per kg per hour, 0.5 ml per kg hour, and 0.3 ml per kg per hour. And the durations are 6 hours, 12 hours, and 24 hours. So I'll just make you practice once again. When it comes to stage 1 of AKI in a patient, the serum creatinine should be between 1.5 to 1.9 times of normal, and urine output jo normal hota hai, that is 1 ml per kg per hour. Here it's gonna be 0.5 ml per kg per hour for 6 consecutive hours. This means that the kidney failure has started. He is in stage 1. When he moves on to stage 2, it would be doubling of serum creatinine to 2.9 times, with urine output decreasing to 0.5 ml per kg per hour for 12 hours or higher. And when it comes to 3 times elevation, that means he's gone into stage 3, and this would be associated with usually creatinine ratio of 4 milligram per cent, and the urine output would be less than 0.3 ml per kg per hour for 24 hours. So this is simple a definition which you need to remember for acute kidney injury, with one of the important causes for pre-renal being especially important MCQ wise important cause for pre-renal acute kidney injury is hepatorenal syndrome. For the renal variety, the important cause to be remembered is hemolytic uremic syndrome. And for the post-renal variety, though there are multiple causes, but one of the important ones is benign prostatic hyperplasia. Also remember that to differentiate between the pre-renal and the renal variety, the test that we use is called as FeNA, that is fractional excretion of sodium. If you read a question that says fractional excretion of sodium in a patient is less than 1%, it is a pre-renal variety, and fractional excretion of sodium more than 1%, that is called as the renal variety of acute kidney injury in a patient. So we can easily differentiate by looking at the urine osmolality and the urinary sodium values of the patient. Coming to the next slide guys, we need to remember biomarkers of structural injury with respect to the kidney. One of the important markers is KIM1, kidney injury molecule 1. Then is neutrophil gelatinase associated lipocalcin. I mean, you read this name, looks like an immunity test, and these tests we are going to be doing in the urine of the patient. So it's urine KIM1, it's a urinary neutrophil gelatinase associated lipocalcin. The point is that serum creatinine will take hours to rise. We can't wait for hours. Like we are having biomarkers for myocardial infarction, we are having biomarkers for liver injury. Like one of the most specific tests for liver damage is SGPT. So at least we are saying doubling of SGPT is a criteria for damage to the liver. Similarly here, damage to the kidney, especially the tubules, will cause these biomarkers to turn positive, and that is where the names have been asked, that is KIM1, NGAL, and interleukin 18. As far as the calculation of the GFR is concerned, ideally the method to be remembered is don't go by the years or anything. One of the important methods to be remembered for calculation of GFR of the patient is CKD EPI cystatin C. I mean, this is the best method for calculation of the GFR of the patient. I'll just jot down the information before you. GFR calculation. In a physiology class, they will obviously talk about inulin clearance. I don't dispute that. If the question talks about inulin clearance, PAH clearance, urea creatinine clearance, and glucose clearance, then from these obviously the answer is inulin. But the point is, these are not practical aspects. The practical aspects is what I'm teaching you right now, or I've taught in a routine discussion, that is like a CKD EPI cystatin C formula. This can be the best method for calculation of GFR. Then can be MDRD, modification of diet in renal disease formula. The advantage of modification of diet in a renal disease formula will be that this will take into incorporation the gender of the patient, weight of the patient, and even the race of the individual. Then is obviously the older one, that is the Cochrane-Gold formula. But these are three specially recommended terms which I want you to remember for GFR. And if they ask you the order of sequence, then these are from the older ones to the new ones. The older one is Cochrane-Gold formula, and the latest one is CKD-EPA cystatin C formula for calculation of glomerular filtration rate. If the glomerular filtration rate of the patient is less than 60 ml per minute, 1.73 meter square of body surface area, for 3 consecutive months, obviously with evidence of proteinuria as well, then I will say that the patient is having CKD, that is chronic kidney disease. Coming to the next slide, guys, there are various methods for calculation of GFR, but one that I want you to be very familiar with is Cochrane-Gold formula. Though ideal answer is CKD-EPI, but why this formula is to be remembered by you is because I just want to sensitize you to the fact that suppose you are having a 40-year-old female whose weight is 40 kg because she is a known case of CKD, so her weight is less. In this lady, the serum creatinine of the patient is perfectly normal, that is, let me say 1 milligram %. So you will get an impression as if everything is fine, though I said she is a patient of renal failure. So let us apply this formula: 140 minus age into weight, 72 into serum creatinine. This would be 4000 divided by 72. Now if you apply a bit of mathematics here, I can say the fact that something in the range of whatever value that is coming is something in the range of about 50 ml only. And considering that she is a female, if I divide this by 0.85, if I go into mathematics here, though you can use a calculator, the GFR of this lady is shockingly only 40 ml per minute. Look at the surprising thing that I taught you guys, that in Cochrane-Gold formula, you can see the fact that though the serum creatinine might be factorially normal, the GFR is only 40 ml per minute. So if you calculate the stage of CKD, she is already in a CKD stage of at least stage 3 CKD. So that's why I have been emphasizing this fact that serum creatinine can be falsely normal also, or serum creatinine is a specific test, but then the point is it takes some time to get risen. I mean, by the time she goes into end stage renal disease, malnourished patient, and a 40 kg is the only weight of the patient, so therefore serum creatinine may not be accurately telling you the renal status. That is why we are devising these formulas. So this lady is shockingly having CKD stage 3. That's the importance of using these formulas that I mentioned before you. And we are obviously having advanced software now where we take into consideration race of an individual. We can take into consideration the length of an individual. So obviously the accuracy increases. Next, we will revise aspect related to autosomal dominant polycystic kidney disease, that is ADPKD. When it comes to this disease, we know the fact that the genes involved are PKD1 and PKD2, which are related to chromosome number 16 and chromosome number 4 respectively. The usual reason why these patients would come to you in an autosomal dominant case would be flank pain. The second reason would obviously be the incidence of UTI in the patient is increased, mostly pyelonephritis. Then stone incidence is increased in this patient, and the stones that develop in these patients is going to be urate stones. Urate stone is not nephrocalcinosis. Please be very clear. Nephrocalcinosis is calcium oxalate stone. Then these patients would be having increased incidence of renal cell cancer. The cancer in these patients can be bilateral also. The most important reason why these patients come to you is because of flank pain and high blood pressure. The reason for high blood pressure is the low GFR of the patient secondary to progressive destruction of the kidney parenchyma. The most common cause of death in patients of polycystic kidney disease should be primarily remembered as hypertension related complications. In these patients, the value of blood pressure once is high, there is a progressive downhill course for the patient because the high blood pressure will affect target organs plus obviously damage this already damaged kidney. The most common extra renal manifestation that is encountered in these patients is presence of liver cyst. Apart from the liver cyst, guys, these patients can be having a pancreatic cyst and even a splenic cyst also. The word to be remembered is for autosomal recessive variety, the most common extrarenal manifestation happens to be a congenital hepatic fibrosis. So you can understand that liver cyst versus liver fibrosis, they're very closely terms. For dominant, it is liver cyst. For recessive, it is congenital hepatic fibrosis. The cardiovascular association of these patients would be mitral valve prolapse. When it comes to the central nervous system manifestation of these patients, a AV malformation in the form of berry aneurysm could be present in the patient. And then most importantly, I can say the fact that the GI manifestation of this patient, which is very neglected, is colonic diverticulosis. For diagnosis of this condition, one of the important investigations that can be done is either ultrasound or a CT abdomen. And when you do an ultrasound or a CT abdomen in the patient, more than 2 cysts per kidney between the age of 30 to 59 years of age is the usual diagnostic criteria. For management of hypertension, ACE inhibitors will be used, and then subsequently, as the kidney parenchyma is getting progressively damaged, we will have to go for renal replacement therapy in the form of transplantation of the patient with a bilateral nephrectomy. Normally we don't do a bilateral nephrectomy, but in this case a nephrectomy would have been done, and a lot of these patients are addicted to opioids. That opioid addiction, I would say, primarily comes because of the flank pain, which is present from a very young age. For ARPKD variety, remember that the chromosome involved is 6. The extrarenal manifestation should be remembered as congenital hepatic fibrosis. Why I decided to write it down is because congenital hepatic fibrosis can contribute to development of portal hypertension in the patient and can cause a variceal bleed. So in patients of autosomal recessive variety of polycystic kidney disease, apart from renal failure, he might include the word variceal bleed in the patient. Why are the cysts so black? They're so black because hemosiderin is being produced due to breakdown of hemoglobin inside these cysts, and these cysts are not communicating with the collecting system of the kidney. That is why the hematuria is not a presentation of this particular condition, but due to stretching of the capsule, due to the tension, due to bleeding inside the cyst, flank pain is obviously one of the manifestations that is encountered in the patient. Coming to the next slide, you can see a glomerulus, which is normocellular glomerulus. I can say why a normocellular glomerulus, because there is no increased neutrophilic infiltrate. You can see all pink cells present here. There is no bluish cells or bluish infiltrate present. So that is why I am saying it is a normocellular glomerulus. Then in one part of the glomerulus, you will notice this pink hyaline eosinophilic deposit. This is a hyaline eosinophilic, that is a pink deposits which are present inside the glomerulus of the patient. And at the same time, along with this hyaline eosinophilic deposits, you can notice that in the tubules of the kidney of the patient, the tubules look perfectly normal. The lumen is absent, unlike a myeloma kidney where the tubules could be blocked by Bence-Jones proteins. Then on the right hand side, this looks like a blood vessel which is fairly well developed. The lumen of the blood vessel is fairly narrow. So blood vessels are fine, which are on the right hand side of the image. Tubules are on the contralateral side. Therefore, the pathological diagnosis of this patient will be given as FSGS, that is focal segmental glomerulosclerosis. Coming to the next slide, you can notice the fact that these are some nodular deposits which are present all over the major segments of the glomerulus. So therefore, the diagnosis in this particular case would be kept as nodular glomerulosclerosis, which is a feature that is encountered with the patients of diabetic nephropathy. So I just wanted to highlight 2 slides which can be given to you. One is focal segmental and second is nodular glomerulosclerosis of a diabetic kidney. Diabetic nephropathy will take at least 5 years to develop with type 1 diabetes and 20 years to develop with type 2 diabetes mellitus in a patient, and it will develop only in those patients in whom HbA1c is more than 7%. If they ask you that how do you monitor the progression of diabetic nephropathy, then obviously you will be using serum creatinine for the patient, because the higher is the value of the serum creatinine, the values will increase. But because serum creatinine rises late, urine albumin creatinine ratio UAC or albumin creatinine ratio ACR, either of the two terms can be used to explain the progression of damage in the kidney of the patient. So you can just look at the two contrasted images that have been given to you, one for focal segmental glomerulosclerosis and the second one is for nodular glomerulosclerosis of diabetes. When it comes to diabetes per se, the overall the commonest presentation is obviously diffuse glomerulosclerosis and Armani-Epstein change. The next immunofluorescence study is showing a linear pattern, very characteristic and very easy to pick up. Even if I zoom it in, you can notice that this is a pretty straightforward linear pattern of staining of the basement membrane of the kidney of the patient. So this is a feature that would be encountered with respect to patients of Goodpasture syndrome. Goodpasture disease or Goodpasture syndrome is the terminology which is to be remembered by you. Goodpasture will be having anti-basement membrane antibodies. Remember the fact that anti-basement membrane antibodies will be causing two manifestations. One of them that you would be getting in the patient will be hemoptysis, and the second manifestation that will be developing in the patient would be hematuria. The combination of hemoptysis and hematuria is a very classical diagnosis, and treatment would be with steroids. This is an example of type 2 hypersensitivity reaction. If you get a triad where hemoptysis, hematuria, and epistaxis is also there, then you obviously have to think in terms of Wegener's granulomatosis in a patient. Looking at the next slide, guys, we look at full house effect of lupus nephritis. In fact, even if I don't show you the image per se, which is a classical one and a repeated one, that all you need to remember is this word full house effect, which is with respect to a game of cards. Just like you have these various varieties of cards present with respect to a winner in a game of cards, similarly here the analogy is that immunoglobulin A, immunoglobulin G, immunoglobulin M, then complement, they're all deposited in the subepithelium and subendothelium. That's my keyword I want you to remember, that the classical situation for full house effect of lupus nephritis would be subepithelial, subendothelial deposits in a patient, and lupus nephritis is one of the important reasons for mortality in active SLE infection. I'll reiterate once again, first decade of infection, I've already told you in SLE, the first decade of life, the cause of death is infection, but active SLE word written is lupus nephritis, and in case he mentions after 45, it is obviously going to be answered by you as accelerated atherosclerosis. Then histopathologically speaking, one is wire loop lesions, which are characteristic of lupus nephritis, and there are a total of 6 stages of lupus nephritis, out of which stage 4 is the one that is usually the common one. Coming to the next slide, guys, you just need to remember and revise the manifestations of CKD, which can be handled aggressively by using A, B, C, D, E. A stands for using or keeping HbA1c under control, and we shall obviously be stopping metformin and giving insulin to the patient, and the insulin that would be given would be 80% of the total calculated dose. Remember, insulin is excreted via the kidney, so we need to basically regulate the amount of insulin given to the patient, otherwise it will cause hypoglycemia. For keeping the blood pressure of the patient under control, ACE inhibitor would be used, which would be like captopril or ramipril, preferably ramipril. C would stand for keeping the cholesterol of the patient under control, and this would be done by using high intensity statins in the patient. For the D component, I want you to remember that in these patients, because vitamin D synthesis is lesser, so by compensatory mechanism, calcium is less and PTH will increase. Because PTH will cause bone reabsorption and weakening of bones, therefore cinacalcet will be used in the patient to inhibit the release of PTH. E stands for erythropoietin, which is deficient in this condition, so injections of erythropoietin will be given so as to take care of the normocytic normochromic anemia. For acute hyperkalemia, we obviously gonna use calcium gluconate and insulin drip. But for chronic hyperkalemia, what we do is that we shall be using molecules like patiromer, or another molecule that can be used is sodium zirconate. These are drugs which are useful for management of chronic hyperkalemia in a patient, and obviously we can use the resin also. The resin would be sodium polystyrene or calcium polystyrene sulfonate. For management of the hyperphosphatemia in renal failure, for binding to the phosphate, what we can do is we can be using lanthanum carbonate for the patient. Hyperphosphatemia, it is lanthanum carbonate to be used for management of the patient. Instead of lanthanum carbonate, another molecule that is used is sivolimer. In fact, sivolimer is obviously to be given priority over lanthanum carbonate for the patient on a efficacy scale, I would say. So these are drugs which are useful for management of patients with CKD, and if the GFR starts reducing, then either a transplantation or a hemodialysis needs to be done in the patient. Okay guys, in the next image we shall be focusing on aspects related to respiratory system. You can see that there is a very predominant periorbital edema present in this particular individual, and this periorbital edema is primarily because of the involvement of the chest of the patient. There is an air leak, there is a pneumothorax in the patient. Had I not shown you this X-ray, you could have thought of this periorbital edema for nephrotic syndrome or for kidney disease or for cirrhosis of liver, and even heart failure can cause periorbital edema in a patient. But considering the concomitant X-ray given finding of the patient, the periorbital puffiness which is present in this patient is best explained by the pneumothorax that is personally basically suffering from. Now, how am I saying that this is a pneumothorax? One, if you look at the X-ray of this patient, you can see shadow of air even with respect to the heart of the patient. So this X-ray is showing evidence of pneumomediastinum anyway. One of the highlight of pneumothorax that is seen in this particular case, if you compare the two sides there, is presence of deep sulcus sign. This claustrophrenic angle looks relatively more deeper than the one on the contralateral side of the patient. I'll use a different ink to highlight the contralateral side. So one of the highlights is what you read as deep sulcus sign. Then the next thing to be remembered is that in the chest X-ray of the patient, the lungs look more black than normal. I put plus signs to say lungs look more black than normal, and you will also notice that there is no vascularity. I mean, the blood vessel shadows are definitely not encountered here. So since you are having a deep sulcus sign, no vascularity, a hypertranslucent lung, and a presence of a subcutaneous emphysema in a patient, the final diagnosis of this patient can be given as that of pneumothorax. Either he could talk about injury to the chest contributing to pneumothorax, or it could be described as spontaneous pneumothorax with respect to rupture of the bulla in the lung. When it comes to tension pneumothorax, mostly he will give you a scenario of a bullet injury to the chest or a stab injury to the chest. With respect to spontaneous pneumothorax occurring in a patient, the scenarios that could be given to you could be that of a emphysematous patient. He will begin by saying tall thin smoker having a sudden onset blueness of the lips and respiratory distress that is due to rupture of the bulla. Or he might describe a very tall person. He might say that the arm span of this person, arm span is more than the height of this particular individual. Or he might say the fact that this person is having a lens dislocation. So I'm talking about Marfan syndrome that could be contributing to pneumothorax in a patient. Or he can describe a very tall and a thin person with very flexible skin and hyperextensible joints. People call him Rubber Man. He has participated in various reality shows where he can contort his body into a glass container. I'm talking about a person having Ehlers-Danlos syndrome, where there is extreme flexibility of the joints and obviously a very stretchable, flexible skin in the patient. Or he can give you a pediatric scenario where a child who is on Staph aureus pneumonia treatment is having a pneumatocoel rupture, and that will cause a sudden onset cyanosis to develop in the patient. So these are the usual scenarios for pneumothorax that he will give you, and then he will mention that the patient is having a sudden onset distress. The auscultatory finding of pneumothorax would be that air entry over that particular area of the chest would be absent, and breath sounds would also be absent. Like normally we are able to hear vesicular breathing, but in this patient the vesicular breathing over the chest would also be missing. For pneumomediastinum in a patient, he might give you a auscultatory finding of Hammond crunch sign. Hammond crunch sign is as if somebody is walking on snow with leather boots on. The sound which is produced is like when your feet would dip into freshly fallen snow. So the crunch is the sound that is heard, and that's the auscultatory finding of pneumomediastinum that is to be remembered. This is obviously not to be confused with a finding that is called as Hammond sign. That is, if you will be feeling over the periorbital area of the patient, because there is air below the skin, so when you press, the feel that you will get would be as if you pressing on a bubble wrap. Like if you order a gift from Amazon, they basically gift it wrap in a bubble wrap, so the feel that you will get is for a bubble wrap. So the finding, if you press, palpatory finding that I'm teaching you is called as Hammond sign. So Hammond sign is a palpatory finding, the feel of a bubble wrap when you press on the periorbital swelling, which is because of the air below the skin of the patient, whereas Hammond crunch sign is a auscultatory finding that you basically have to remember. Now we will look at what are the treatments at our disposal for management of these patients. The answers will depend upon whether the question is on tension or pneumothorax, so I'll just write down the nomenclature here. For tension pneumothorax in a patient, because most of the time the scenario given to you will be that of unrecordable blood pressure. In fact, pneumothorax can contribute to development of obstructive shock. What do you mean by the word obstructive shock is that there would be decrease in the venous return to the right side of the heart. That decrease of the venous return is because of the kinking of the great veins in the patient, that is the superior vena cava and the inferior vena cava, which will result in a unrecordable blood pressure in the patient. The question will usually say what is the first line management for this patient, which is that you're gonna put a wide bore needle into the chest of this guy. This wide bore needle will cause sudden decompression of the air, so the moment the needle goes into the pleural cavity, you will hear a hissing sound from the back side of the needle, which will basically reveal the fact that there is a presentation of air in the pleural cavity which you have allowed to evacuate. After that, we'll attach a three-way stopcock behind the wide bore needle. Why? Because the air can go into the chest by the wide bore needle. So you adjust the three-way stopcock in such a fashion that no air goes into the chest, though from the site of the bullet injury, air will still continue to go inside. Once the air will accumulate once again in the chest, once again the BP will begin to fall, and you will again turn the stopcock so that you can evacuate the air. So the stopcock has to be used for intermittent decompression of the chest of the patient, because from the bullet injury site, air will continue to go inside. Meanwhile, a surgeon will work to put in a chest tube, that is an intercostal drainage tube, which will be deployed in the patient in the fifth intercostal space in the mid-axillary line. And once you put this chest tube in the patient in the mid-axillary line, it will basically help you in ensuring the management of the hemopneumothorax of the patient. Once this is done, then a patient would be subjected to emergency thoracotomy, where whatever is the cause of the trauma will obviously be handled, like a bullet will be removed or hemostasis will be achieved, or I would say a lobectomy might be required in the patient because the lung part has been totally destroyed. In case in the question of spontaneous pneumothorax cyanosis is given in the question, then for management of this particular individual, straight away a chest tube, an intercostal drainage tube will have to be deployed in the fifth intercostal space in the mid-axillary line in the patient, so that the decompression can occur. But suppose in the question there is no mention of the word cyanosis, then the management of this patient would be given as needle aspiration. In lots of cases of spontaneous pneumothorax, there may not be immediate cyanosis in the patient, so we will be using a 100 ml syringe, attach it to a needle, ultrasound guided, and then remove the air which is in the chest cavity of the patient. So the answers will depend upon the scenarios given to you in the exam for tension as well as spontaneous pneumothorax, and the following guidelines have to be followed. For tension pneumothorax, whether cyanosis is given, not given, it is straight away to insert a wide bore needle followed by a chest tube in the patient to relieve the obstructive shock component. In spontaneous pneumothorax, because there's a rupture of the bulla, the amount of air that accumulates in the chest cavity is relatively limited, so therefore hemodynamic compromise may not occur immediately. Once you remember pneumothorax, then they have given you and asked you scenarios for pneumomediastinum. In fact, if you look at the chest x-ray here, you can see the air which is very clearly delineating the heart borders. So this x-ray is suggestive of pneumomediastinum, and it is not that only trauma to the chest could be contributing to it. He might give you a scenario Boyer-Haff syndrome, where the person was vomiting, there was retching, and then the esophagus in the lower 1/3 had ruptured, and the air will accumulate in the mediastinal cavity of the patient. In fact, this pneumomediastinum is very clearly visible on a CT chest, where you can definitely see the shadow of the heart of the patient. If you can just see the markings here, this is obviously the vertebra. Then I would say inside here is the spinal cord of the patient. Then anteriorly you can see this would be the bronchus of the patient, the left and the right main segmental bronchus of the patient, because the section is below the trachea. Then you can see some part of the pulmonary artery of the patient. This looks like to be the aorta. Then the right side of the heart, this could be the superior vena cava of the patient. And then you can notice that anterior to the heart of the patient, this area where the arrow is present, this is showing a black rim of air around the heart of the patient. So air around the heart is always a feature that is a feature of pneumomediastinum in a patient. And pneumomediastinum is commonly encountered with conditions like Boerhaave syndrome and obviously with trauma around the chest. For management of pneumomediastinum, if he says what is the treatment of pneumomediastinum, it is mainly surgical correction and high flow oxygen. Whatever is the cause of that needs to be treated, and high flow oxygen needs to be given, and gradually the air around the heart of the patient will be reabsorbed. In fact, if they give you a chest x-ray, you may notice that sometimes the air may not be seen around the heart, but the air will be present, as you can see, a thin sliver of air which is present below the heart of the patient. So continuous diaphragm sign of pneumomediastinum is also reflected here. One more finding that is of pneumomediastinum that has to be remembered is called as Naeglerio sign. In this case, you can see, if I just put pointers here, you can see the V of the air which is present at the I would say the costomediastinal angle of the patient. One more sign that can be appreciated is called as Naeglerio V sign, which might be on the mediastinal side where the heart and the lungs are meeting. So this would be the I would say the cardio mediastinal side, and the finding is called as Naeglerio V sign. So there are three images that I've shown you for pneumomediastinum, and if they ask you that what is the best way to identify pneumomediastinum, then the answer is a CT chest. But if he says that how do you diagnose Boerhaave syndrome, then obviously contrast extravasation also has to be demonstrated. So plain CT chest is very good to demonstrate pneumomediastinum in the patient. But if he says specifically the word Boerhaave syndrome, which is the cause of pneumomediastinum, then it would be CT chest with oral contrast. Without a esophagogram where oral contrast, the patient was made to sip, and it will obviously spill over into the mediastinal cavity where extravasation of the contrast is demonstrated. It would not be possible to be sure about presence of Boerhaave syndrome in a patient. After pneumothorax and pneumomediastinum, the next thing on the agenda would be to take care of consolidation. Like in this image, you can see a right middle zone consolidation in a patient. The chest x-ray of this patient is showing extensive whiteness in the middle zone, and even the right heart border in the patient cannot be appreciated. So since right heart border is not getting appreciated in this condition, the term that we will use for this would be called as Silhouette sign. The presentation in this case is that of pneumonia. The auscultatory finding of pneumonia would be bronchial breathing. Obviously, the patient will be having standard features of fever, respiratory distress, rusty sputum, rusty for mainly pneumococcal pneumonia, because one of the leading causes of pneumonia happens to be pneumococcal pneumonia. So rusty sputum would be present in the patient, and the auscultatory finding is not to be answered as crepitations. The auscultatory finding for this patient should be answered as bronchial breathing. In bronchial breathing, the inspiratory-expiratory ratio of the patient will not be same as normal person. Instead of 1:2, the inspiratory-expiratory ratio of the patient would be 1:1. So remember that for pneumonia, the auscultatory finding, the main diagnostic finding is bronchial breathing, and then the diagnosis of the patient will be made on the basis of a sputum culture and cytology. On sputum microscopic examination, neutrophils will be present. If neutrophils are present, that is usually indicative of presence of a bacterial pneumonia. In viral pneumonias, mostly lymphocytes would be present, or they would be neutrophils. At least neutrophils are not encountered in a viral pneumonia. Gram stain will obviously help you in identifying. and a culture report will be awaited after 48 to 72 hours. Now, if a person cannot produce sputum, you can help him by giving him a saline nebulization that will liquidify the secretions, and then he can expectorate. But if a person is very sick and he cannot produce the sputum, then what will you do is you can use a transtracheal culture. The reason why I am so hell-bent on doing a culture is because I want an etiological diagnosis. I basically want to find out what organism is causing this particular infection in the lung of the patient, because without that, treating this patient is like shooting in the dark. You don't know what is the target. The chest X-ray of this patient will be showing obviously a patch. It would be usually one whole lobe that is involved, so the term that we use for it is called as lobar pneumonia. And then we will obviously decide to treat this particular patient. Now, what are the organisms that are responsible for development of pneumonia in a patient will depend on the situation given to you in the paper. Like if he simply says the fact that what is overall the most common cause of pneumonia, you know it is pneumococcus, both for adult and pediatric age group. If pneumococcus is not given, then in outpatients it would be a atypical pneumonia. The atypical pneumonia to be remembered is Mycoplasma pneumoniae. But in some questions, instead of trying to write it this way, he will rather ask you that a patient of community acquired pneumonia is hospitalized, which organism is responsible. Now listen to my words very carefully, because I'm not talking about hospital acquired pneumonia. Hospital acquired pneumonia is a pneumonia that develops in an individual after 48 hours of admission. Like for example, a patient was admitted in my hospital for elective cholecystectomy, and after 48 hours of stay in the hospital, he's having a new onset pneumonia. That is hospital acquired, that is Staph aureus obviously. But here, look at the trick in the question. He will say a pneumonia patient is hospitalized. That means that he had a pre-existing episode starting from the community. And which organism is responsible? The answer is again Streptococcus pneumoniae, both for ICU and non-ICU, because obviously if the person is more sick, we will admit him to ICU, because indication for ICU admission would be curve score of the patient more than 2. Equal to and more than 2, and if the score of the patient is 1, then it is a non-ICU patient, hospitalized patient. So remember the words that I'm saying very carefully. If he specifies the word a hospital acquired pneumonia or new onset after 48 hours of admission, the answer straight away is Staph aureus. But if he specifies that a person of community acquired pneumonia is hospitalized in the ICU, which organism is responsible, then the answer is Streptococcus pneumoniae. He had infection from the community, no? And then he got admitted because the curve score was elevated. That is why we admitted the patient. The backup answers are Mycoplasma pneumoniae and then Staph aureus for non-ICU and ICU patients. But I think that if he will give you a question on this, the question will be very cleverly worded as a guy with community acquired pneumonia is hospitalized in ICU. Which is the organism? Don't start answering as Pseudomonas or Staph aureus in a patient, because that is intrinsic to ventilator. Not everybody in ICU on a ventilator, no? Not everybody who's hospitalized is always on a ventilator. So avoid the impulse of answering Staph aureus, except for the situation described to you on the top, where it is a new onset pneumonia. He did not carry this infection into the hospital premises. He was not admitted with a diagnosis of pneumonia. He was admitted for elective cholecystectomy and then ended up with the development of pneumonia subsequently. Also remember the fact that in geriatric age group patients, viral pneumonia could be there. One of the important causes of viral pneumonia is influenza A, especially if it describes an old man. Like this old man is taking a homeopathic supplement or Ayurvedic supplement that is containing steroids. He is not aware of it, so he might end up with development of infection with influenza A. And influenza A can cause a viral pneumonia which needs to be treated with imantadine or rimantadine in the patient. So the points to be understood is organism specific approach has to be care. For hospital acquired pneumonia, it is Staph aureus. If he specifies in the MCQ ventilator associated pneumonia, then it is Pseudomonas. And here also the trick can be that he can say the word non-MDR. What I mean by non-MDR is that this person was admitted in my hospital, but the tubing that was being used on the ventilator was same as the previous patient. So the tubing was not sterilized properly, and therefore a person can get even Streptococcus pneumoniae. MDR is straightforward. No aspects, no problems, no controversy with MDR. That is Pseudomonas. It could be Klebsiella. It could be Acinetobacter. In fact, Acinetobacter has deliberately been asked because a couple of studies in AIMS revealed Acinetobacter to be more common than Pseudomonas, but we'll go by Harrison and that says Pseudomonas and then Acinetobacter. Gram-negative organisms are both MDR and non-MDR, but point is Pseudomonas mainly is to be answered for the right hand side, and for non-MDR for ventilator-associated pneumonia, strep pneumonia. Let me rephrase the data for you so that this becomes permanent imprint. If the question begins by a patient by saying hospitalized patient of community acquired pneumonia who is currently admitted into the ICU, which organism is responsible? The answer would be given as Streptococcus pneumoniae only. The reason why he was admitted into the ICU was because the curve score of the patient was equal to or more than 2. The curve score may not be given, but he will begin by saying hospitalized patient. But if he begins the MCQ by saying hospital acquired pneumonia, then obviously the answer would be Staphylococcus aureus. Even if he says healthcare associated pneumonia, that is HCAP, healthcare associated pneumonia, would be like a person who was admitted in my hospital for 4 hours for dialysis, but from the environment of the hospital he got infected. For ventilator associated pneumonia, if MDR and non-MDR is not given, then the answer should be given as Pseudomonas. And obviously if he specifies the word non-MDR ventilator associated pneumonia, which he will, because traditional impulse of ours as doctors is that when we read ventilator we start thinking about the nasty organisms, the answer would still be given as Streptococcus pneumoniae. And the reason for this is that the tubings that were used were not sterilized properly, like in government hospitals. Like I worked in a government place, you guys work in a government place. Half the time the ventilator tubings are not sterilized properly and they are being reused in a patient, and that can definitely result in a disaster situation of the new patient. He was admitted for, let me say, swine flu, and he got bacterial pneumonia super added. Once we have remembered the organisms, then I want you to also remember organisms with respect to the following situations. If he begins by saying what is the commonest cause of pneumonia in an alcoholic patient, don't straight away start answering Klebsiella. The commonest organism contributing to pneumonia in alcoholic is same as you and me from the community, that is Streptococcus pneumoniae. I'll say like this: if he says what is the common cause of pneumonia in an AIDS positive patient, don't straight away answer zero VC, because in AIDS positive patients initially it is community acquired infection only. Only when the CD4 count will become less than 200 that the zero VC start appearing. Otherwise even they will end up with strep pneumonia only. When would you answer Klebsiella in a multiple choice question is when he will give you the following information. If he mentions the word red currant jelly sputum, that is one aspect, red currant jelly sputum. Or if he mentions the word bulging fissure sign, that is accumulation of pus in the interlobar fissure, then you should think in terms of Klebsiella pneumoniae to be answered. That is also called as Friedlander's pneumonia or Friedlander's bacillus. When it comes to COPD in a patient, the organism is Haemophilus influenzae. Structural lung disease like cystic fibrosis or bronchiectasis. Both for MCQs of cystic fibrosis and bronchiectasis, because cystic fibrosis is one of the causes for development of bronchiectasis. The organism would be Pseudomonas aeruginosa. The reason is recurrent hospitalization. Bronchiectasis patients of bronchuria, they are having repeated hospitalizations. So the organism walking in from the hospital environment, especially from if he's accustomed to ventilator or was subjected to ventilator, is Pseudomonas aeruginosa. And a new organism that I'm nowadays finding is Burkholderia cepacia. Why you have to study regarding aeruginosa and Burkholderia cepacia is because both of these organisms will form a biofilm in the lung, and this biofilm that will develop in the lung will be impervious to antibiotics. Because the biofilm is impervious to antibiotics, I would say God help this guy, because now even if you give the best quality antibiotic for this guy, you will notice the fact that the patient will definitely not respond to your treatment, because the bacteria forming a security covering which is gonna prevent the penetration of antibiotics, and that in fact leads to bronchiectasis. When it comes to dementia or stroke, it is oral anaerobes. The reason why is it so is mainly because these patients might be having impaired airway defenses. Like for example, a patient of amyotrophic lateral sclerosis, he is having weakening of his bulbar musculature, throat musculature. So because a person will not be able to swallow his saliva, the impaired airway defenses will predispose the individual to infection with anaerobes. So stroke patient, ICU patients, because you sedate them, no, you put them on neuromuscular paralysis, so they are not able to swallow their saliva, and that is why we do recurrent suction in these patients every 2 hourly or every 3 hourly. Aggressive suction is not recommended, but regular suction of throat contents is to be done in ICU patients. And in a patient who's having impaired airway defenses secondary to neuromuscular paralysis is subjected to anaerobes, because one of the common organism in the oral cavity is anaerobic organisms. One of the leading causes for lung abscess is MRSA, that is a community acquired methicillin resistant Staph aureus. But if that is not in the options, then it is anaerobes in a patient. Most of the time the scenario of lung abscess could also be ICU patient. Then you can neglect the next two aspects because they are mainly for American situations. But yeah, stay in a hotel or a cruise ship, it is Legionella pneumophila. Legionella pneumophila is important. Why? Because this could be even water droplets which could be responsible for inhalation. Now I repeat my statement, water droplets. I mean, normally we read water for GI infections, no? Water for a pneumonia, because water droplet inhalation in this particular individual is responsible for contributing to the manifestation of pneumonia. Then this organism can be associated with SIADH, that is syndrome of inappropriate ADH secretion, and because of this there would be a dilutional hyponatremia. Look at the surprising thing I'm teaching you, electrolyte imbalance in a pneumonia patient. This will explain why the MCQ will say confusion, disorientation, and even seizures. I mean, mark my words here, you know, if I say seizures in a pneumonia patient due to hypoxia, it is understandable that oxygen deficiency will be contributing to that. But if a person is having electrolyte imbalance and there is a development of hypoxia that secondary to a pneumonia, that's very weird, no? That is why we call it atypical organism. So Mycoplasma, Legionella, and Chlamydia are atypical organisms. Then would be local influenza activity. That's obviously influenza virus. As I was saying, winter season, old man, he's on steroids also, maybe due to some homeopathic supplement. It could be influenza. Exposure to bats is histoplasma, that is also called as Cave's disease, or is also referred to as Darling disease. And then when we talk about exposure to birds, it would be Chlamydia psittaci. Psittacosis is the reason for this. The organism for this Chlamydia psittaci is sensitive to doxycycline. Exposure to rabbits is tularemia, that would be Francisella tularensis. Eschar formation might be noticed in this particular case because this would be transmitted by the bite of ticks. And then exposure to sheep and goats, that could be Coxiella burnetii, that is also called as Q fever. Q fever can also contribute to infective endocarditis in a patient. Because of the atypical aspects I've highlighted here, that's why it's a good idea to actually remember these aspects that I have said before you for organism-specific approach to pneumonia. For treatment of the patient, would you be treating the patient on OPD basis or IPD basis is based on CURB 65 score. In CURB 65 score, C would stand for confusion or disorientation in a patient. By a mental abbreviated score, we can calculate that. Then is elevated burn. Why is the burn is elevated? Because patient will develop sepsis and therefore organs can be affected in the patient. So sepsis can explain the elevated burn of the patient. Respiratory rate, count by yourself, don't leave it to the nurse, more than 30 per minute. Blood pressure of the patient on admission less than 90/60, and age of the patient that is more than 65. These are parameters which are like highly important for decision for admitting the patient, and each of these parameters is given 1 point each. Now suppose you have calculated the score of the patient to be between the final score of a pneumonia patient between 0 to 1. That is like, for example, in the MCQ, he is saying that age is more than 65 and everything else is normal, no disorientation, respiratory rate normal in the patient, I will be treating the patient on OPD basis. But if the score of the patient is 2, that is like he's disoriented, he's having elevated blood urea nitrogen also, then we will obviously admit the patient. In any IPD based patient, I will anyway have to admit him. That would be a score of 2, and if the score is more than 2, then ICU based treatment has to be initiated in the patient. So he can obviously give you scenarios of the curve 65 score in the patient, and then you will have to treat the patient. Let us see what will we do if the score is 0 to 1. According to Harrison, if the score of the patient is 0 to 1, in outpatient department, the first line antibiotic to be given to any patient is clarithromycin. It is either clarithromycin or azithromycin. Macrolides can be given, or for that matter of fact, the second antibiotic that can be used is doxycycline. So do not in the MCQ answer amoxicillin and amoxicillin clavulanic acid. And I've seen most of the chaps, casually answering amoxi or amoxiclav. It is amoxi is anyway, not useful. It's like if I'll put it like this: you treated somebody with amoxicillin for pneumonia and it got treated. It was actually not pneumonia. You thought it is pneumonia. So it is amoxiclav that is used, which when will you use, I'll mention subsequently. But if he simply begins by saying that the curve score of a particular patient who has been admitted in the hospital is, let me say, 1, like only age is more than 65, then you will have to give clarithromycin or doxycycline for the patient. But then he will describe in the question presence of comorbidities. What I mean by comorbidities is like he will say diabetes mellitus patient, and he was admitted in the hospital a couple of weeks back, like let me say this January. This patient was admitted, and then again in March he was hospitalized. A diabetic patient is having recurrent hospitalization for pneumonia. So in those circumstances, the first line antibiotic that you have to give is respiratory fluoroquinolone. You will start the patient on moxifloxacin. Don't answer levofloxacin, because levofloxacin, yeah, can be used, but it is more effective against gram-negative organisms. And respiratory fluoroquinolone, moxifloxacin and gemifloxacin are the ones which are first recommended. Instead of this, an alternative approach can be that you can straight away start the patient on amoxiclav 2 gram BD. So amoxiclav is only to be answered in a case of community acquired pneumonia where there is a comorbidity given or antibiotic for recurrent hospitalization has been given. And remember the fact that this data that I mentioned here before you is for a curve score of 1. This is for curve score of 1. That is, I repeat again, no comorbidities, nothing given in the question. Pneumonia patient, age more than 65, what will you do? Answer is azithromycin/clarithromycin. If he specifies diabetic patient with recurrent hospitalization, answer is moxifloxacin. Moxifloxacin in Indian exam is a little dicey to answer. Why? Because in India, tuberculosis can be coexistent. And when you give moxifloxacin, you are killing TB bacteria also. So TB diagnosis will become difficult. That is the reason you will see a lot of your specialists writing not moxifloxacin but amoxiclav. But I would like you to answer from Harrison perspective only, because that is what is written. First line approach for the patient is though it's written, or obviously any of the two can be used. But then fluoroquinolone, that is moxifloxacin, and amoxiclav are two answers. Now let us see what does he say for inpatients. If he begins the question by straight away saying that it is an inpatient, you have admitted him to a non-ICU scenario, and he says what will you do for the patient? It is again moxifloxacin, or it could be other antibiotics which I mentioned like beta-lactam, like ceftriaxone or cefotaxime, iltapinum, plus a macrolide can be used in the patient. So see, he's saying still moxifloxacin and a beta-lactam plus a macrolide in the patient. So remember the fact that first line answer is moxiflag. If not, beta-lactam like cefotaxime plus azithromycin can be started. If it is a ICU patient, then the answer is given as beta-lactam, and obviously it's a plus here. The plus would be with azithromycin in a patient, or fluoroquinolone as listed above for a non-ICU patient. So let's quickly revise this information so that we can just make this a permanent memory. You see, in a multiple choice question, the possibilities given to you can be one, that he's simply saying that curve score of the patient is 1 and the patient is admitted right now. What will you do for the patient? Your answer would be that you will give macrolides to the patient. The same scenario, curve score of 1 is given to the patient, but he's describing comorbidity in the question, or he is describing recurrent hospitalization due to the same episode. Recurrent hospitalization would not mean 3 years back, it would mean in the previous 3 months. Then the antibiotic to be answered by you in this scenario would be given as moxiflux, or another antibiotic that can be given is amoxiclav to the patient. Assuming that the curve score of the patient is 2, then in those circumstances there can be two possibilities: a non-ICU patient and an ICU patient. For a non-ICU patient, he says that you can start the patient on moxiflux. You can notice the fact that moxifloxacin is given in all of these first, though in Indian wards they will lot of times say don't give moxiflux because patient could be having concomitant TB, but I would still recommend you to answer it from the Harrison perspective. Now an alternative approach which is available is that you could be giving for this particular patient ceftriaxone, and along with this you could be adding clarithromycin or azithromycin to the patient orally if he can take, or IV if he is not able to take. For ICU patients in the patient, the primary management of the patient would be to administer beta-lactam once again, that is ceftriaxone for example, and along with this you will have to give azithromycin for the patient. You will notice the fact that in inpatients the treatment is almost the same. It is just that for inpatients he has mentioned for non-ICU he has given you two approaches, and he has given a single approach for a ICU patient. So that's the final approach that I want you to remember for these patients. You see, AIIMS has created a separate website where they're using an antibiotic policy that they are basically using that is having some differences from what I have said, but I would recommend you, especially since we are preparing for the NEET exam. So this is the data from Harrison that I would like you to remember for our patients who are having pneumonia. Let us now study regarding what will be the treatment of hospital-acquired pneumonia and ventilator-associated pneumonia. The moment he uses the word VAP or HAP, all of this will go outside the window. You will notice that none of the drugs that we discussed here, like for example, we discussed clarithromycin, we talked about moxifloxacin, or combination of ceftriaxone with macrolide. All of these are out of the window now. Now straight away, the treatment of choice for the patient is piperacillin and tazobactam in the patient to be given on a 6-hourly basis. And this is if he gives you no risk factors for resistant gram-negative pathogen. What I mean by risk factors for resistant gram-negative is recurrent hospitalization in a patient. In those circumstances, you will have to choose one from each of the column. That is, like for example, you will give piperacillin, tazobactam to the patient, and you can add to that, for example, you can add tobramycin to the patient or amikacin to the patient. So the basic point is that in ventilator-associated pneumonia MCQ, the answer is not to be given from the previous scenarios. It is not azithromycin, no moxifloxacin. It is straight away piperacillin, tazobactam, or a combination of piperacillin, tazobactam with aminoglycosides like amikacin, gentamicin, or tobramycin in the patient. And if the risk factors for MRSA is present, then obviously linezolid can be added, or if it is vancomycin sensitive, then vancomycin can be given. If it is vancomycin resistant, it is obviously daptomycin, but otherwise linezolid or vancomycin can be used in the patient. This would be treatment strategy for VAP, ventilator-associated pneumonia. Also, because these patients are bound to be more sicker, so to monitor these patients, the clinical score, the clinical pulmonary infection score or CPIS score is used. The clinical pulmonary infection score will be having the following parameters: temperature, then is TLC. So 2 T's here, temperature, TLC. Then the third T is tracheal secretions, whether they present purulent or not. So repeating once again, temperature of the patient, TLC of the patient, and tracheal secretions are the 3 T's. Then you will take into consideration lung status of the patient. So oxygen status of the patient and pulmonary infiltrates in a chest X-ray, whether they are localized or diffuse. I mean, obviously, if there is a patchy infiltrate, that would be 1. If it's localized lobar pneumonia in adults, that would be 2 marks. Then is progression of the pulmonary infiltrate, whether it is increasing or decreasing, and then is the culture report, whatever organism was isolated in the patient. So there are 3 T's. I repeat again, that would be the temperature of the patient, especially if temperature is very high or very low, that is a cause of concern. If you are having elevated TLC, that's obviously a cause of concern. Band cells, immature neutrophils, no? Normally neutrophils would be having 3 nuclei at least. The band cell would be an immature neutrophil with a U-shaped nucleus. Then tectal secretions, whether they purulent, these are parameters to be considered. Lung status is oxygen status, that is monitored by PaO2 FiO2 ratio. For ARDS, that is acute respiratory distress syndrome, the PaO2 FiO2 ratio is to be taken as less than 300. That is 200 to 300 is mild, 100 to 100 is moderate, and less than 100 is severe. But here the value is 240. And pulmonary infiltrates on a chest X-ray, progression of these pulmonary infiltrates and culture of the tracheal aspirate are parameters of clinical pulmonary infection score. The clinical pulmonary infection score is for patients of ventilator associated pneumonia, and this will obviously tell you the prognosis of the patient. I'll put it like this: patient is hypothermic, TLC is 50,000, tracheal secretions is frank pus, oxygen levels are PaO2 FiO2 ratio of 100. There is extensive infiltrates in the chest X-ray of the patient. The infiltrates are increasing day by day, and bacteria have been cultured. Then obviously the prognosis is bad in the patient. So CPIS score is to monitor evaluation of patients of ventilator associated pneumonia. Then this image that I'm showing you is actually of a child. It's of a girl, in fact. She's, let me say, 14 years of age, and this girl, 14 years of age, is having complaints of fever, respiratory distress, and breathlessness. On auscultation in this patient, you are noticing bronchial breathing over one part of the chest, or may not be noticed also, and then the chest X-ray finding is given. You see, you can see a well circumscribed shadow in the chest X-ray of this patient. Had I given you a history of an old person having this, you could have thought it could be a lung abscess, it could be a cancer. But at a young age, with a fever of, let me say, 3 days, respiratory distress for 3 days, and there is a purulent sputum in the patient, the diagnosis of the patient would be given as a round pneumonia. So history is obviously to be important, especially in pediatric age group. You will notice that you may not get that classical lobar pneumonia finding, but the pneumonia might be located in one area which might look like a mass. If I remove the markings, it looks like a mass. No, if I did not give you any history, you could have thought of this as a shadow of a developing lung abscess, or for that matter of fact, you could thought of it as a huge lung cancer which is causing a mass lesion that can be seen on a chest X-ray of a patient. But giving the history of this patient, the diagnosis would be given as round pneumonia, and usually this is diagnosed as a mass only. I mean, it is identified as a mass only, and as you give antibiotics, there is improvement of the patient. In fact, the X-ray would look very scary because you will think that the child could be having maybe a lymphoma which is causing big lymph nodes and is causing a circumscribed shadow like this. But like I said, in this case, short history and resolution to antibiotics would make the diagnosis of the patient as that of round pneumonia. The next description that is given to you is that of an AIDS positive patient. You can notice the extensive bilateral infiltrates present in the patient. So because the chest X-ray of this patient was showing extensive infiltrates, the doctor has decided to do a bronchoalveolar lavage of the patient. There is chest X-ray showing bilateral lower lobe infiltrates. Then in these circumstances, I have decided to do a bronchoalveolar lavage of the patient. You know, the diagnosis is obviously pneumocystis jirovecii, but he'll talk about the stain that is used here. So the stain that is used here to isolate the organism, and the sporocysts of this is gomori methamine stain. And then you can see this black appearance of the sporocysts of the organism. So the diagnosis of this patient is obviously very obvious, that is pneumocystis jirovecii. I would like to make it very clear to you the fact that the most common cause of pneumonia in AIDS positive patient is always going to be answered by you as streptococcus pneumonia only, but only when the CD4 count is less than pneumocystis jirovecii aspect would come. Now let us look at the investigations that we will do for jirovecii, and especially because this is a fungal pneumonia, so you should be aware of a blood test for this patient that will pick up the infection, and that is called as beta-1,3-glucan test, BDG. Beta-1,3-glucan test is a non-invasive test to diagnose fungal infection, because normally if you do a sputum culture in this guy, you will have to use Sabarot's dextrose agar and the colonies will take a long time to appear. I don't have that much of time at my disposal, so I will use a non-invasive test, beta-1,3-glucan test. LDH values are also elevated in the blood significantly in patients of pneumocystis jirovecii. Obviously, a fungal pneumonia is present in a patient, so I will be taking a bronchoalveolar lavage and I will be staining it with gomorimethamine stain to identify this particular organism. Lots of time they might deliberately mention features like alveolar arterial gradient. You see, because this pneumonia will be a interstitial pneumonia, so the diffusion of gas from the alveoli into the blood vessels will be reduced because the pus is in this case in the interstitial space. So A represents the pressure of the gas in the alveoli and the small a represents the pressure of the gas in the blood vessel, and because small a will become lesser, therefore this gradient will increase. Normal alveolar arterial gradient for you and me is 5 to 15 millimeters of mercury, and in this condition, because the small a will become lesser in the patient, so the gradient will increase. So increased alveolar arterial gradient is a feature of pneumocystis jirovecii pneumonia. Why? Because it's a interstitial pneumonia in a patient, so that's why we will have this feature. For treatment of these patients, the antibiotic is cotrimoxazole. For prevention also, in this particular case, we will have to use the same antibiotic. So this is for treatment also and for prevention purposes also, that cotrimoxazole would be used in the patient. And because cotrimoxazole can cause allergic reactions also, so desensitization has to be done in patients of AIDS. What I mean by desensitization is you start with the lowest possible therapeutic dose and gradually accelerate. If you have used cotrimoxazole in AIDS patients, you understand what I'm saying. If you use the standard dose, the side effects of cotrimoxazole, rash, fever will appear, and because of rash and fever, what will happen is patient will stop coming to you. And AIDS patients, if they don't come to you regularly, then opportunistic infections will develop in these patients more frequently. So therefore desensitization implies that you have to start the patient on the lowest possible therapeutic dose and then gradually upgrade, and you can basically then manage the patient relatively more effectively. So for workup, I'll do the slide again, so rolling. Therefore, for workup of these patients, we will obviously check for LDH, and then we will also try to do a quantitative PCR in the patient, because quantitative PCR can differentiate between colonization and active infection. Plain PCR cannot differentiate, because if you are just doing a real-time PCR in the patient, a real-time PCR will simply tell you that yes, the organism is present. If you want to differentiate colonization from active infection, it is a qPCR or quantitative PCR that should be done for this particular patient. And as I told you, nowadays BDG, that is beta-1,3-glucan test, is a cell wall component of many fungus, and therefore it has been useful for diagnosis of candida infection, aspergillus and pneumocystis, but this is not useful for diagnosis of mucormycosis. So rhinocerebral mucormycosis that you study in a diabetic patient, that definitely cannot be identified by basis of beta-1,3-glucan test in a patient. So these are informations which are to be remembered, especially from pneumonia perspective, which is one of the highly asked topics most of the time in the exam. So you have to be thorough with this. Coming to the next slide, guys, you can again see a triangular opacity in the chest x-ray, but this triangular opacity is not similar to that of pneumonia, because if I show you the image of pneumonia once again, you will notice that the patch in pneumonia was much more ill-defined. They was not having a very sharply delineated borders, but this one is having very sharply delineated borders. In fact, this triangle is having the base on the pleural surface and it points towards the hilum of the lung. So this is a radiological finding that is technically called as Hampton hump, and this is encountered in patients having pulmonary embolism. If you look at the x-ray of this patient, you will definitely be able to appreciate the aortic knuckle, but then you can also notice the fullness in this particular area of the pulmonary artery, because most patients who are having pulmonary embolism will also be having pulmonary artery hypertension, because there's a blockage of the main pulmonary artery or maybe one of the branches of the pulmonary artery. The pulmonary artery segment will look relatively more prominent. The final diagnosis of this particular chest x-ray is not to be given as pneumonia. but is to be given as pulmonary embolism due to two facts that I've highlighted: prominence of the pulmonary artery segment of the patient and a very well-defined opacity in the lung, which is due to pulmonary infarction, which has occurred in this particular case. Why this occurs can also be understood. Like I can say this is a patient who is having deep vein thrombosis, or he has undergone a total hip replacement, or he has undergone a total knee replacement, or the patient has undergone a pelvic surgery. If any of these risk factors are given, you anyway know that pulmonary embolism would be present and the Wells criteria will come into picture. So what will happen in the patient would be, if this is the representation of the heart of the patient, this is the aorta, which would be originating from the left ventricle, and then would be the pulmonary artery, which would be originating from the right ventricle and would be bifurcating like this. A right ventricle is not actually on right, it is inferiorly located, as I've said a couple of times. So the thrombus will go into the lungs of the patient, then will usually go to the right side, and let me say this is the right pulmonary artery ascending branch and the descending branch. So this is where the embolus is. This embolus is causing physical blockage of the descending branch of the pulmonary artery, due to which the area distal to this will begin to die, and that is why there was this wedge-shaped opacity that was occurring due to pulmonary infarction developing in this particular case, and urgent thrombolysis must be started in these patients to prevent mortality in this particular case. In the setting of any one of the data mentioned above, and then he says that the patient is having respiratory distress with or without chest pain, there is a pleuritic chest pain in the patient, and he gives you a X-ray which is given like the one that I have highlighted before you. The diagnosis of the patient would be given as pulmonary embolism, a wedge-shaped opacity that is called as Hampton hump. Though not very visualized in this image, I can say that the proximal pulmonary artery segment will definitely dilate in this case. This dilatation of the proximal pulmonary artery segment is called as Palla sign, though not very well appreciated in this particular case, but then yes, Palla sign is also a feature of pulmonary embolism. The screening test for this particular case is D-dimer assay. The investigation of choice for this condition is CTPA. A CT pulmonary angiography, I'll show you the image subsequently, is the best way to confirm the diagnosis. And since this person would be having an unrecordable blood pressure, to convert this unrecordable into recordable, thrombolysis is recommended, and the thrombolysis that would be done in this case would be with L-Taplis. Remember, for stroke we use Re-Taplis. It's easier and faster to give. L-Taplis requires an infusion over 1 hour, and in stroke, because time is the essence, I want to give the drug relatively faster. So when it comes to Re-Taplis in a patient, you usually will be using it in stroke, and L-Taplis for both STEMI and for massive pulmonary embolism in a patient. The learning is that not every opacity in a chest X-ray is to be thought of as pneumonia. Look at the clinical information provided in the question, and yes, even if the clinical history is not given, this should not be answered as pneumonia, considering the very characteristic delineated boundaries of the radiological image given to you. So you should still think in terms of a pulmonary embolism in the patient. Moving to the next X-ray, this is regarding an alcoholic who on the Holi festival, this alcoholic, he took drugs also. He took a cocktail of drugs and alcohol, and then he was continuously sleeping for 2 days. And his mother was worried because he is intoxicated. He's opening his eyes and looking at her and recognizing her also. But then he told her that, "Mom, I'm very sleepy. Just let me sleep." So young chap, racy lifestyle, his mother let him sleep. And after 2 days when he woke up, he was having fever. He was having pus in the sputum bronchorium, and a very shocking symptom. Pus in the sputum bronchoria. He thought he had not brushed his teeth, so that's why maybe something like this. He brushed his teeth and still the bronchoria was persisting, and foul smell was coming in the breath of this guy, and there was breathlessness also. So he has decided to go to the physician, which happens to be you, and when you ran an X-ray on this chap, you notice this well circumscribed opacity, which is revealing a air fluid level, because you can see that the pus will settle at the bottom in this particular case, and there is air superiorly which is looking black. And any chest X-ray that is having a presence of an air fluid level, any chest X-ray that is having a presence of a air fluid level On a chest x-ray, the diagnosis of the patient for air fluid level will always be kept by you as lung abscess. So the clinical diagnosis of this particular patient based on the x-ray is lung abscess, and now immediate treatment for this patient has to be started. Now what treatment will be started in this patient is not a linezolid or vancomycin or any drugs for Staph aureus, because this guy was under intoxication with a cocktail of alcohol and drugs. Therefore this particular individual is having impaired airway defenses. Because this individual is having impaired airway defenses, so in those circumstances, in this particular individual, the person could not swallow his own secretions, and the common organism that is present in the lung cavity, in the oral cavity, is anaerobes. So the anaerobes of this particular individual would go into the lungs. I'll put it like this: anaerobes are present in the oral cavity of yours and mine. We swallow our saliva, so nothing happens to us. But if there is a micro aspiration of saliva in an intubated patient, in a comatose patient, in a person with impaired airway defenses, then anaerobic lung abscess would develop in the patient, and the drug of choice for this condition should be answered not from the perspective of Staph aureus. So don't answer vancomycin, linezolid or piperacillin tazobactam. You have to give to this guy clindamycin right away, because this is an anaerobic lung abscess in a patient. I reiterate my statement: one of the leading causes is obviously a community acquired MRSA, but here the perspective is that of an anaerobic lung abscess. Why? Because the patient was having impaired airway defenses. And let me just zoom into the x-ray once again for your better understanding. I hope if I remove the markings also, you can see the whiteness of the pus at the bottom and the air fluid level which is present in the chest x-ray of the patient. I'm going to erase this also, so that this you can highlight even better, and I think is a very characteristic and easy to identify shadow in the chest x-ray of the patient. Moving to the next perspective, I am representing before you a chest x-ray which does not give you any history, but even without a history, you should be able to pick up the very classical deep sulcus sign of the patient. The moment you pick up the deep sulcus sign, it should tell you the fact that we are dealing with pneumothorax in the patient. And then if you look at the markings of the lung of the patient, yes, in the periphery, I would say the vascular markings are relatively reduced in the patient. Do not comment on the position of the heart, which will obviously go to the contralateral side, because in emergency we do a AP film. So position of the heart and trachea is not to be commented, because in emergency AP film you really can't comment on this. But yes, a very characteristic deep sulcus sign would make the diagnosis of this patient as that of pneumothorax, even if the history is not given. And this looks like an x-ray for baby, so probably this baby after birth was resuscitated and the doctor gave ambu bag, which was bigger in the ambu bag used was bigger in size, so there could be a iatrogenic pneumothorax that could have resulted in this child. And considering the mediastinal shift in the patient, we will have to deploy a chest tube in this particular case. The x-ray was shown to you to mainly sensitize you to the deep sulcus sign of the patient where the air is present. Now compare this x-ray with where you are getting a classical Ellis curve, that is a pleural effusion present in a patient. I mean, normally this is how the reflection of the lung should be, but you can notice this entire white area which is reflective of the pleural effusion. You can see the costophrenic angle on the contralateral side looks decent to me, but I can definitely notice that there is a slight displacement of the heart due to a substantial effusion that is developed in this patient. The highlight of this particular image which can be given in respiratory system is blunting of the CP angle, and that points towards the diagnosis of pleural effusion in the patient. While answering these questions, keep a tab on the fact that the upper border of the fluid should not be straight, because the moment he will say the upper border is straight, like if in this case if it was straight, then I would have answered as hydropneumothorax, but this is plain hydrothorax in a patient because meniscus sign is elicited, or instead of a meniscus sign we will call it a Ellis curve. Pleural effusion can be easily identified on a CT chest. If he says what is the investigation choice for pleural effusion, this would obviously be CT, and if CT chest is not given, then ultrasound chest would be a good idea to answer. Normally the fluid in the pleural cavity is about 5 to 15 ml, but if the amount of fluid is more than this particular amount, then obviously it can be picked up on a chest x-ray. In a chest x-ray, in a PA view, how much fluid should be present for clinical detection, then the amount of fluid on a PA view should obviously be in more than 100 ml, going up to 200 ml. That is usually on PA view it can be detected. In lateral view obviously up to 200 ml, but if he says clinical detection is possible at, then clinical detection of pleural effusion requires at least 300 ml. Why I'm saying this is because of the fact CT can pick up anything more than 10 ml also, but if it is clinical detection, 300 ml chest X-ray, at least a PA view, the blunting of the CP angle would be present in the patient. Lateral decubitus MCQs are outdated one, guys. A lot of controversy related to it, so I'll not get into that. And then remember the fact that for pleural effusion in a patient, if he is talking about that comparison with ascites, I mean, how much is the minimal ascitic fluid for clinical detection? Then it is 100 ml. Ascites is easier to pick up because of puddle sign, whereas in pleural effusion the fluid tends to settle at the bottom, so it's a little difficult to pick up. I repeat my statement, minimum pleural fluid for clinical detection is about 300 ml, but for clinical detection of minimal ascites, at least 100 ml of fluid should be present. You can turn the patient and then you can go a clinical sign in the patient that would be traditionally called as puddle sign. For diagnosis of pleural effusion, whether it's a transudate or exudate, we will have to use criteria that are called as Light's criteria. The component of the Light's criteria which are to be remembered would be, you would be checking for the pleural fluid protein and LDH values. Do not take into consideration the sugar. The pleural fluid protein values should be more than 0.5 of the total serum protein values of the patient. The total serum protein values of the patient. The pleural fluid LDH of the patient should be more than 0.6 of the serum LDH of the patient, or he might write pleural fluid LDH to be more than 2/3, that is same as 0.6 of the upper reference limit of the serum LDH of this particular patient. So if these criteria are satisfied in a patient, we will say that this is exudate. For you to say a fluid as a exudate, the fluid should be more than, and if the parameters are given as less, then it is a transudate present in a patient. One of the leading causes of a transudative pleural effusion should be remembered as heart failure, and for exudative it is a parapneumonic effusion and then a malignancy. Transudative pleural effusion will never clot, and exudative will always clot on standing because it is serofibrinous in nature. Parapneumonic effusion, if not treated properly, can also deteriorate into development of empyema. Empyema means pus in the pleural cavity, for which again chest tube has to be deployed. So if he says how do you handle an empyema, obviously antibiotics have to be given, but intercostal drainage tube in the 5th intercostal space, mid-axillary line hooked up to a negative suction back would anyway be required. Another important cause for exudative pleural effusion can be malignancy. And if he says what is the leading malignancy responsible for it, then it is lung cancer. Adenocarcinoma of the lung is a peripheral lung cancer that could be responsible. Related MCQ. Malignant pleural effusion is caused by patients having adenocarcinoma of the lung, and if he says malignant ascites is caused by, then malignant ascites happens to be caused with ovarian cancer. For adenocarcinoma of the lung, the problem would be that the fluid will be fairly massive. Like in this case, I have shown the lung tissue literally getting compressed by substantial amount of fluid present in the pleural cavity of the patient, and the moment this patient will turn to one side, the breathlessness will worsen because now all the fluid will gravitate on one side, depending on whether it turns to left or right, but the fluid will gravitate to one side and will put more pressure. See, if he's upright, the pressure is equally distributed across the lung field, but if it's like substantial amount of fluid, you turn to one side, the fluid will gravitate to one side and the breathlessness will worsen. So dyspnea increasing on lateral decubitus position. Dyspnea worsening on lateral decubitus position is what is technically called as trypopnea. This is a feature of a malignant pleural effusion. When you do a therapeutic thoracocentesis in the patient, the amount of fluid that can be removed in a single sitting could be up to 1.5 liters. The reason why we do not remove more than 1.5 liters is re-expansion pulmonary edema developing in the patient. For treatment of this particular patient, we will obviously remove the fluid, it will come back. So I will be injecting doxycycline and doing a procedure in the patient by the name of pleurodesis. This will obliterate the pleural space and it will help in treatment of this patient, because now you would be having adhesions developing between the various layers of the pleura, that is visceral and parietal. So though I am giving my patient restrictive lung disease, right, but the good news is that the pleural fluid would not come back, and this is all because of a tumor which was sitting here, let me say adenocarcinoma sitting peripherally, irritating the pleura. So the pleural fluid will obviously keep on increasing in this particular patient. The preferred site for doing a thoracocentesis in any patient is as low as possible, preferably a 7th intercostal space in the posterior scapular line. So you have to stand behind the patient and poke the patient. So posterior scapular line is the usual site where you put in the needle. Before you put the needle, you should obviously do percussion. On percussion, you will notice that there will be a stony dull note whenever there is a fluid present. If you will auscultate over the fluid, the breath sounds will be reduced in intensity. The reason is the fluid is compressing on the lung parenchyma of the patient, so reduced intensity of breath sounds would be heard, and at the upper level of the fluid, bronchial breathing is heard. Remember my words, at the upper level of the pleural fluid, bronchial breathing is heard, but wherever the effusion is present, if you auscultate over it, it is vesicular breathing only. Usually the lung tends to be compressed, so it consolidates in the upper part of the pleural effusion, so that's where bronchial breathing could be present. But technically speaking, inside the pleural effusion, the part of the lung which is compressed with the lung parenchyma, the upper part is having the upper level bronchial breathing, the consolidated part is bronchial breathing, but the inferior part of the lung, which is submerged in the fluid, which is compressed with the lung, there would be reduced intensity because there is fluid present in the chest cavity of the patient. Then thoracocentesis should be done only when there is more than 1 centimeter of difference between the chest wall and the lung surface of the patient. This is what I'm saying. If on a chest x-ray you measure the distance to be more than 1 centimeter, then this is the indication for doing thoracocentesis procedure in the patient. That is, the fluid is pretty substantial in the patient and needs a therapeutic evaluation. Then they've also asked condition in which the pleural fluid will be having low sugar. So pleural fluid with low sugar is obviously a feature of an exudate. One of the important causes for this with low sugar should be remembered as rheumatoid arthritis. Another one is malignancy, and third is bacterial infections, but not tuberculosis. In tuberculosis, the pleural fluid sugar may be even normal. So if he says that what is the best to identify tubercular pleural effusion, then for tubercular pleural effusion, you will be using a test by the name of adenosine deaminase. ADA, adenosine deaminase levels in the pleural fluid cavity, that is, the fluid is having adenosine deaminase levels to be elevated, is helpful in evaluation of tubercular pleural effusion. Lymphocytosis obviously to be present, but low sugar is rheumatoid arthritis, malignancy, and bacterial infection. Then remember, for rheumatoid pleural effusion, in fact I'll have to use a separate slide for that. If he specifies for a rheumatoid pleural effusion, then remember, for a rheumatoid pleural effusion which is exudative in nature, there will be even presence of cholesterol crystals. This was a recent one in the AIMS that cholesterol crystals in pleural fluid are evaluated in, that is a rheumatoid pleural effusion. This would be an exudate, will follow obviously the Light's criteria. Right-sided pleural effusion. Right-sided pleural effusion is a characteristic feature that is encountered in patients. So remember my words, guys, especially with respect to rheumatoid pleural effusion, it will definitely satisfy the Light's criteria, but one of the special findings of rheumatoid pleural effusion would be presence of cholesterol crystals. That is very characteristic and easy to identify. Cholesterol crystals on microscopic examination are a feature of rheumatoid pleural effusion following the Light's criteria. Then remember a MCQ by the name of right-sided pleural effusion, which is a feature of Meek syndrome. Meek syndrome will be associated with the ovarian tumor by the name of fibroma and athecoma. The counterpart MCQ of this one is called as left-sided pleural effusion. Left-sided pleural effusion is a feature that is very characteristic for surgical emergencies, like acute pancreatitis could be having a left-sided effusion, and that would be called as sympathetic effusion. So especially pancreatitis involving the tail of the pancreas is where you read about sympathetic pleural effusion, or it could be Boerhaave syndrome, rupture of the esophagus, or esophageal malignancy. So you will notice that usually surgical domains are the ones for left-sided effusion. Bilateral pleural effusion is a feature that is seen with heart failure because transudate the pressure is equally distributed. And last but not the least is bloody pleural effusion. Bloody pleural effusion can be seen in tuberculosis. It can obviously be seen in lung cancer like adenocarcinoma or squamous cell cancer or any other lung cancer. And then even mesothelioma can be having a bloody pleural effusion. Bleeding diathesis and trauma I have not written because that's understandable. Then mesothelioma also has a special feature, that is pleural calcification. So pleural plaques or pleural calcification is a feature of mesothelioma. I mean, chest X-ray showing a pleural calcification is a feature of mesothelioma, and this happens to be a cancer which is associated with asbestosis. In which industry should be an individual working in to get asbestosis? So it could be a cement plant, it could be a person working in mica industry where this kind of a scenario could be occurring in the patient. So these are a couple of causes why pleural effusions would be developing in the patient. The next domain to be remembered is miliary mottling. A very characteristic chest X-ray shown here, that is miliary shadows or a snowstorm appearance is present in the chest X-ray of this particular patient. Miliary mottling on chest X-ray is obviously a feature of disseminated tuberculosis, which would be common in AIDS positive patients or HIV positive patients. Since the immunity is lesser, those AIDS positive patients would be having a miliary mottling on a chest X-ray. Then after disseminated tuberculosis, an important cause to be remembered is one of the most common occupational lung disease in India, that is silicosis. Silicosis is the one that is usually encountered in patients who are working either in the glass industry or is encountered in patients who are working in, let me say, rock blasting or sand blasting industry, especially the illegal mining where they use the dynamite to blast the rocks. So the aerosol that is produced there of the air is fairly deadly and can contribute to silicosis, which happens to be one of the common occupational diseases in India. Then chickenpox in adults can be lethal. It can cause bleeding. It can cause chickenpox pneumonia. So varicella zoster pneumonia or chickenpox pneumonia is responsible for miliary mottling. The fourth cause to be remembered for miliary mottling in the patient is hemosiderosis. Here I am saying that the person could be bleeding inside his lung and the hemosiderin deposits could give this appearance. That could be with Good-Pasteur syndrome. You know that Good-Pasteur syndrome could be having a hemoptysis, and that could be not a, I would say, a gross hemoptysis to be coming out in the sputum of the patient, but he's still bleeding inside, and the hemoglobin will then produce hemosiderin and could cause this kind of a picture. Very rarely, fat embolism. You see, in 99.99% cases of fat embolism chest X-ray will be normal. I reiterate again, fat embolism is a clinical diagnosis based on GERD criteria, GURD criteria. In majority of cases of fat embolism, you are not gonna encounter any radiological finding, but since because it's rare, so that's why I'm saying that GERD fat embolism syndrome, especially fracture of the long bones, could be resulting in a miliary picture developing in a chest X-ray of a patient. Then is a disease in which the turnover of the surfactant is affected. Like turnover is, what I mean by turnover is that surfactant is produced in our lungs on a regular basis by type 2 pneumocytes, and then it has to be degraded also. But in this condition, the degradation of the surfactant is defective. The surfactant is produced, but then the degradation of the surfactant is defective, due to which the surfactant will keep on accumulating in the lungs of the patient in the alveoli. These patients will be having this disease since birth, but manifestations will occur in adult age group, and question will say gelatinous pink sputum plugs. This gelatinous pink sputum plugs that would be elicited in the patient would be primarily due to the accumulation of the surfactant in the alveoli of this particular patient, and these are 6 important causes for miliary mottling or chest x-ray. This guys has to stay with you, even if you apply for a JR shape anywhere in any hospital, they'll obviously give you an x-ray and say, okay doctor, tell me the causes of miliary mottling. So you should be anyway able to tell all these aspects that I mentioned before you. And one of the important diseases to be remembered is pulmonary alveolar proteinosis. A HRCT pattern of pulmonary alveolar proteinosis is called as crazy pavement. So crazy pavement pattern or crazy pavement appearance is a feature which is very characteristic of pulmonary alveolar proteinosis. Coming to the next slide, guys, this is a slide that is showing a very characteristic flattening of the diaphragms in the chest x-ray. You can notice that there is a loss of curvature of the diaphragm, that you see flattening of the diaphragms. Then you will also notice the fact that in this condition the lungs of the patient are expanded and they're covering the heart of the patient. So I'm using the word tubular heart to describe the configuration of the heart of this patient. I mean, normally heart borders are very clearly appreciated. Generally speaking, the lungs are more black than normal bilaterally. Vascular markings are there, like you can see the white vascular markings, but hyperinflation is definitely present in this patient. So considering the 3 scenarios of flattening of the diaphragm, a tubular heart and a hyperinflation, this is definitely a patient of COPD. He is definitely a patient of emphysema, and this patient would in future require a lung transplantation. For calculating the severity of patients of COPD, that is especially emphysema, we use what is called as Gold classification, and the MCQ on Gold classification has been asked in the exam, so that is why I would like you to remember it. That is, they had asked about the severe variety. Well, if you try to remember it like this, FEV1, FVC less than 0.7 and FEV1 predicted values, it will become a little difficult for you to remember this information. So let me just quickly make you practice this, the Gold classification. Let us now quickly try to remember how to remember the Gold classification for severity of COPD in a patient, the traditional data. In the Gold classification, they have subclassified this into mild, moderate and severe. The errors are usually coming because they are having very severe also. So our brain is programmed to understand like 3 points, diametrically opposite ones, but then 4 points it becomes a little too much to handle, and that's where errors of judgment can come. The common thing between all of them would be FEV1 divided by FVC ratio is less than 0.7. But now, though this would be a common data between all of them, you have to remember the fact that if in a question you mention FE1, FVC less than 0.7, that is obviously the mild variety. For the moderate variety, you have to remember that the FEV1 of the patient will be between 50 to 80%. For the severe variety, the FEV1 of the patient will be between 30 to 50%. That is one that was asked in the exam, and very severe is less than 30%. On reading the word severe, a lot of guys casually answered FE1 to be less than 30, but that is not the case. For severe, I want you to remember for COPD, remember we're not studying asthma, guys. In asthma, it is like mild, moderate, severe, easy. But here it is COPD that we're talking about. So it is 30 to 50% that is going to be answered by you as severe variety, and less than 30% is obviously the very severe variety for emphysema patient, and this patient will definitely require a lung transplantation. There are various interventions for pink puffer or emphysema. One is obviously a video assisted thoracoscopic surgery where a bulectomy will be done in the patient to prevent the development of spontaneous pneumothorax in the patient. Another treatment that can be done for this patient is lung transplantation, which will obviously be difficult. Quit smoking is obviously the first advice that you would be giving to this patient, and if the damage to the lungs is very severe, then supplemental oxygen would be given, and supplemental oxygen is the mortality reducing intervention for patients of COPD. Remember the fact that whenever you get an X-ray like this which is showing a tubular heart, it is emphysema that is to be primarily considered. Do not mix this with bronchial asthma, in which hyperinflation can be present, but during an acute attack. During an acute attack of asthma, we will obviously be using a SABA, a short-acting beta-2 agonist that will be having a blue cap. You can see the color of the cap of SABA, salbutamol, is blue. But for LABA, that is long-acting beta-2 agonist, the color of the cap would be green in color. This would be a green cap, because you have to tell the patient that LABA is for prevention, and then even for steroids, that is inhaled corticosteroids, the color of the cap would be brown in color. You can see the brown color of the cap. So remember the information that I'm saying here, which is that brown cap for inhaled corticosteroids, green cap for LABA, and blue cap for SABA. And LABA and inhaled corticosteroids together, they are used for prevention of asthma. Whereas for acute attack in a patient, obviously you will have to use a short-acting beta-2 agonist in a patient. Then there could be attacks which could be intermittent, mild, moderate, or severe. How do you remember it? Intermittent attack would be less than 2 days per week. Mild is more than 2 weeks per week. Moderate is a daily attack, and severe is symptoms all through the day in the patient. So let's practice. If you say intermittent asthma, as the English term goes, it would be less than 2 attacks in a week. Mild is more than 2 attacks in a week, but it should not be daily. If it is daily, it is moderate asthma. So if you remember moderate, I think you can remember both sides of the spectrum. Moderate asthma attacks basically mean daily attacks in a patient. If it is a diurnal variation which is so severe that at night he can't sleep at all, let me say at night, all 7 days of the week he says, "Doc, I can't sleep," and symptoms are present all through the day, that is severe asthma. If it is moderate, it's daily, but he says, okay, at daytime I'm okay, nighttime I can still have problems, but okay, in daytime thankfully I'm okay, doctor, that is a moderate attack. And if it is not daily, it's like 3 days a week, 4 days a week, it is a mild asthma. And intermittent, as the name suggests, is easy to understand, maybe like once a week, or maybe for 1 day or 2 days he would be sick. For patients who are having intermittent attacks, most of the time you will notice that the FEV1 by FVC ratio would remain normal in the patient, but FEV1 and divided by FVC ratios are reduced by 5% usually in scenarios of persistent and severe persistent asthma. The difference between a persistent and a severe persistent asthma would be that the variation of FEV1 would be less than 5% and more than 5% respectively. So that's the main criteria that differentiates between the two. For intermittent asthma, you don't need much. It is like sporadic use of inhaled corticosteroids in a patient. But sometimes, suppose somebody is having daily attacks, then I will have to give him relatively higher dosages of LABA with inhaled corticosteroids and rescue therapy with oral steroids sometimes. And if it is severe, then we might have to use omalizumab in the patient as well, because we have exhausted all our resources primarily. So for prevention of asthma, it is inhaled corticosteroids. For intermittent asthma, we will be using SABA for the patient whenever the attack is coming. But when it is moderate asthma and daily symptoms are present in the patient, you will have to use long-acting beta-2 agonist with inhaled corticosteroids, which you will in fact have to increase the dose from mild to moderate to a high dose. That's because the inflammation in the lungs has to be suppressed. And if it is severe attacks of asthma, then omalizumab has to be used in the patient. As far as the severity of asthma exacerbations are concerned, this I'm now talking about acute asthma exacerbation versus severe acute asthma. So what is severe acute asthma? That will prompt you to hospitalize the patient and start him on nebulization. If you notice that the patient is talking to you not in a complete sentence, but is rather talking to you in words, like he is saying not okay, he is like signaling with his hand that I am not getting breath, then it is severe asthma. The respiratory rate would be obviously increased. Patient will sit upright. Loud wheeze would be present both in inspiration, expiration in a patient, and pulsus paradoxus is often present. Now remember my words, not always present in a patient. And when you say imminent respiratory arrest, which is something even more severe than status asthmaticus in a patient, the patient will not talk to you. Patient does not talk. He is totally silent. The patient will be having paradoxical breathing. The abdominal part of the chest will be working more. There could be bradycardia occurring in the patient, and absence of pulsus paradoxus suggests respiratory muscle fatigue. Please do not be under impression that in respiratory arrest imminent you will not have a pulsus paradoxus. You will have a pulsus paradoxus. But if pulsus paradoxus also is disappearing, that means the fact that he is not breathing. That means that you need to intubate the patient on a priority basis. So when you read this data, you see a lot of guys, they message me, sir, you told pulsus paradoxus is present in respiratory arrest imminently. Yes, it is present, man. It is just that when the disease will become more severe and you know that he is going to go into a respiratory arrest, there would be bradycardia and this will tend to disappear. So this finding can be present or may not be present and is not a diagnostic criteria, absolute diagnostic criteria for determining imminent respiratory arrest. What is that the breathing effort of the patient is so much that he is not even able to talk to you, he is not able to recline, there is a paradoxical breathing in the patient. Those are features of imminent respiratory arrest. For severe acute asthma in a patient, you obviously have to admit the patient and you have to do nebulization with salbutamol. You will also have to give ipratropium bromide. You will have to give IV hydrocortisone to the patient, that is to suppress phospholipase A2 activity in the patient. And aminophylline is gradually being replaced nowadays. We are not using aminophylline currently for management of patients of severe acute asthma because of the toxicity that is associated in the form of PSVT, and urgent intubation is required for patients having an imminent respiratory arrest. So let's quickly revise the aspects for asthma that I have just told you. If he begins by simply saying brittle asthma, then brittle asthma, the attacks can be so severe that patient can die in 1 hour. In brittle asthma, you will also be having presence of diurnal variation of attacks. Not only a nocturnal variation, you could be having a diurnal variation of attacks in brittle asthma. What I mean by diurnal variation is that the peak expiratory flow rate of the patient can vary more than 40% on a daily basis. In asthma, normally symptoms deteriorate at night, no, cold air, but daily variation even in daytime in brittle asthma is there, and these patients have to be given EpiPen, that is subcutaneous epinephrine, and this is the only way that he can use this auto injector, and epinephrine will cause bronchodilation and improve the symptoms of this particular fellow. But if he says, how do you handle acute asthma in a patient? Then it is MDI, a meter dose inhaler, shake well before use, check the residual dosages and deliver a SABA. But if he says, how do you prevent asthma from occurring? Then it is LABA from again a MDI, a meter dose inhaler, and this LABA would be obviously given with ICS, that is inhaled corticosteroids. If he however says that patient is having severe acute asthma where a person is able to talk to you in monosyllables, or he's trying with a sign language and he's just able to say not okay, he can't say I am not okay, not a complete sentence, then for severe acute asthma where pulsus paradoxus will gradually start appearing as he shifts into imminent respiratory arrest. So in severe acute asthma, you would be using nebulization with SABA and hydrocortisone and oxygen and ipratropium bromide for the patient. And the last possibility is worse off than this, imminent respiratory arrest, where muscle fatigue will start coming in, and this condition, the pulsus paradoxus, will gradually start disappearing in the patient because there is a muscle fatigue developing in the patient. So imminent respiratory arrest is urgent elective intubation and put the patient on a positive pressure ventilation in a patient. If he says patient is having severe persistent asthma, then we are not talking about emergency care. We are talking about routine symptoms where severe persistent asthma will be having symptoms all through the day and night. It is for this severe persistent asthma that omalizumab would be used in a patient, and severe persistent asthma is characterized by FEV1 FVC ratio changing by more than 5% on a recurrent basis, or if you check it, you know, the duration or variation of this can be in excess of more than 5%. Whereas when I say only persistent asthma, then FEV1 FVC ratio would be less than 5%. This is not a 5% value. This is a 5% change with and without medication in a patient. So before medication, after medication change that we are talking about. These are a couple of aspects for asthma that I basically want you to remember. Okay guys, let's start with the next topic. You have to realize in this particular CT scan, you can very clearly notice the very dilated airways present in the patient. Especially I would like to highlight the tram track appearance present here, which makes the diagnosis very straightforward and easy for you. That would be bronchiectasis, which is a large airway disease. One of the important causes of bronchiectasis can be cystic fibrosis, which is characterized by excessively thick lung secretions, that is mucoviscidosis. So due to the stasis of these secretions, you would be having insipidation and secondary infections, and therefore the secondary infections can result in development of bronchiectasis. One of the common organisms that will colonize the airways in cystic fibrosis would be Pseudomonas, and the second one would be Burkholderia cepacium. Now, I have explained to you the fact that these are very nasty organisms. Why I'm saying nasty is because these organisms can form a biofilm in the lung, and this biofilm in the lung could be harboring or could basically make the bacteria totally resistant to antibiotics, in a sense that the antibiotics will not be able to reach the area where the bacteria are present. So due to the formation of the biofilm, extensive amounts of fighting between the security system and the bacteria is going on, and the bacteria is still not dying. So this would cause pus, that is dead neutrophils, and that will fill up even the large airways of the patient. Another important cause for bronchiectasis that should be remembered is allergic bronchopulmonary aspergilloma, or ABPA. Allergic bronchopulmonary aspergilloma is a colonization of the airways by this fungus by the name of Aspergillus fumigatus, and then the hypersensitivity reaction to this would result in development of what is called as central bronchiectasis. This is itself a very peculiar term, central bronchiectasis, because traditionally speaking, when you read about bronchiectasis, the pus should gravitate to the lower part. I mean, lots of time in bronchiectasis, you would have lower lobe involvement, but this would be one condition where you would get a central bronchiectasis. Then when it comes to tuberculosis will involve the apex of the lung, and therefore the manifestation will be peculiar in a sense that one, upper lobe is involved, two, the condition will be having paucity of purulent secretions, bronchiectasis sicca implies dry bronchiectasis is a feature that is seen with tuberculosis. Another rare cause, though rare but MCQ is important for bronchiectasis, is Kaltenegger syndrome. Kaltenegger syndrome would be characterized by ciliary dyskinesia, the reason for this being the dynein arm of the cilia being defective, so the ciliary motion is affected. You have to appreciate the fact that in cystic fibrosis, the problem is of the secretions which are thick and viscid. Here the problem is not of secretions, it is the cilia that are not functioning properly. So these patients will be having recurrent sinusitis, they would be having also bronchiectasis, and there will also be a problem by the name of I would say situs inversus or dextrocardia in the patient. In fact, they have given a situation like this, that the person has dextrocardia, recurrent lung infection, sinusitis, and what disease could be present, that is Kaltenegger. Remember that in the triad of this condition, infertility is not included. The reason for this being that the infertility that is seen in Kaltenegger syndrome is encountered only in male patients, but the infertility is not encountered, I'm putting across, in female patients. So because infertility is not a constant feature of Kaltenegger syndrome, so therefore infertility is not included in the triad of Kaltenegger syndrome. These are some of the important causes which are responsible for bronchiectasis, and one of the easy ways to pick it up on a CT would be hugely dilated airways, as I can just zoom in and highlight those dilated airways, which are much bigger in caliber, and they also appear relatively thick walled. You can see the reactive changes that have occurred, which will make the wall appear relatively whitish. Then you can obviously see the white structure which is present here, which looks like a blood vessel, which could be mainly the pulmonary artery. You can also see in the middle this black shadow. This would be that of the lower segment of the trachea, and then the upper part of the lung is the one which has been visualized here, where dilated airways can be seen. Now if you compare this image with the one that I'm highlighting now before you, you will notice the fact that there is a lot of I would say abnormality noticed in the periphery of the lung of the patient. So I'll just try to sketch it before you what it really means. In the periphery of the conducting airways, if I draw like this, I mean you would be having terminal bronchioles, respiratory bronchioles like this, and then obviously the terminal units of gas exchange, that is alveoli, would be present. Now what is happening in this condition is appearance that is technically called as tree in bud appearance. You can see this budding appearance which is appearing in the smaller airways of the patient, and this tree in bud appearance that we notice is very characteristic for two things. One could be tree in bud appearance is a characteristic feature of endobronchial TB, The second aspect to be remembered is that tree in a bud appearance is a characteristic feature of patients who are having pneumocystis jirovecii pneumonia, which can affect the smaller airways of the patient. So this characteristic tree in bud appearance, though there are lots of differentials for it, but endobronchial TB and jirovecii pneumonia are the two important ones to be remembered. Now, some guys might say that why is it not a honeycomb appearance? So honeycomb is, guys, I'll put it like this. I mean, honeycomb will have these septations, no? Like a honeycomb of a honeybee that would be having these septations which are not visualized here. So I would not call it a honeycomb appearance, but would be calling it a tree in bud appearance. And these are very classical ones which I have shown before you on a CT, and these can be image-based questions as well. Coming to the original tract, when it comes to bronchiectasis in a patient, one of the classical clinical features that is encountered in a patient of bronchiectasis would be bronchoria, that is pus in the sputum. The second feature that has to be highlighted is presence of hemoptysis. There could be pus which could be eroding the airways of the patient. There could be even changes in the nails of the patient, that is presence of clubbing. And most importantly, because there is pus present, so you could be hearing crepitations which are coarse crepitations, and these crepitations are mainly gonna be on the lower part of the lung, and that's basal, but at the same time they would be asymmetrical, left and right may not be equal. So bronchoria will make you think that you are reading a question of chronic bronchitis, because he may deliberately begin here by saying a smoker. But the point that tells you that it is not chronic bronchitis would be hemoptysis and clubbing, because you don't get hemoptysis in chronic bronchitis, and you don't get you don't get clubbing in patients of chronic bronchitis. Plus, chronic bronchitis is a small airway disease. This is a large airway disease which can be picked up by a high resolution CT scan, and then a cause specific treatment can be done for evaluation of the patient. Two classical features on HRCT for this patient would be tram track appearance, and the second classical feature would be that of a signet ring appearance. For management of these patients, obviously antibiotics have to be given, mucolytics have to be given. Mucolytics will not alter the course of the disease. For management of these patients, one of the primary approach would be postural drainage. That is, like, patient will be advised to sleep in a particular position to prevent the lung secretions from going deeper. And the second thing that's very important is chest physiotherapy. I want this guy to exercise his chest muscles very regularly so that the chances of insipidation of secretions can be significantly minimized. The MCQs to be remembered, two must-know facts here are: one to remember is issue of central bronchiectasis, and second is bronchiectasis sicca, which are two standard questions which are anyway asked. Let's move on to the next part of our slide, where I'll add up some details for cystic fibrosis, that is mucoviscidosis. This occurs due to a mutation that is called as F508 mutation. The chromosome that is involved in cystic fibrosis is chromosome 7, and the pattern of inheritance is autosomal recessive, so 25% chances of expression of the disease in the next generation. Now, in this patient, the abnormal protein that is formed is called as CFTR protein, that is cystic fibrosis transmembrane receptor protein, and let us see what is the problem due to this protein. Since this disease can involve the exocrine glands, even the endocrine glands are involved, but since it can involve the exocrine gland secretions, so the manifestations that would be encountered in these patients would be: one, these secretions would be chloride rich. The second manifestation of these patients would be that in this particular case, you will also notice that the secretions will be very thick and viscid, and because they are thick and they are viscid, so insipidation risk would be significantly increased, or the clearance of these from the airways would be impeded. If the question begins by saying what is the earliest clinical feature of cystic fibrosis, then do not answer bronchiectasis and pneumonia right away. For the early part of the disease, the early manifestation in this patient is based on the fact that the stool of the baby, that is the first stool of the baby, you know, is meconium. It is jet black in color and should be expelled in first 24 hours. Now see, the baby was inside the mother for so long, the stool should have solidified. It did not solidify because the pancreatic juice basically contains enzymes The pancreatic juice contains multiple enzymes like amylase, lipase, trypsin, chymotrypsin. So they tend to keep the meconium in a liquid format, and this blackish stool is expelled by the baby in the first 24 hours. But in cystic fibrosis, what happens is that the pancreatic juice is very thick and viscid, so it is stuck in the pancreas. It is not able to come outside. And because the pancreatic juice is very thick and viscid and it is not able to come outside, therefore what happens in these patients is that there would be insufficiency of secretions in the lungs, resulting in meconium ileus. Meconium ileus basically means paralysis of the gut of the patient because the stool is stuck, and therefore the MCQ can begin by saying early manifestation of cystic fibrosis is, your answer would be delayed passage of meconium. One of the important causes of delayed passage of meconium by a baby that you are anyway aware of is anorectal malformations, ARM. But after anorectal malformations, another important cause which would be significantly ruled out is Hirschsprung's disease. But assuming the fact that anorectal malformation and Hirschsprung's disease have been ruled out, then another important cause to be remembered is the topic that we're studying, that is cystic fibrosis in a patient. So these are a couple of causes which anyway have to be evaluated, and in this case the baby was having meconium ileus. The fecal matter is stuck inside. So let us now study what will be the investigational choice for meconium ileus. This would be answered by you as gastrogafin enema. And for gastrogafin enema, the advantage will be that the chances of water intoxication in a child will also be lesser. And if he says what is the treatment of choice for meconium ileus, the answer would be same, gastrogafin enema. Why? Because the enema will liquidify the stool, so the fecal matter will be passed out in the patient. So this is one of the early manifestations. Now the second problem would creep up in this patient because the airways are ciliated columnar epithelium. And in this condition, what's going to happen is that the secretions are very thick and viscid. So I'm just showing the secretions are sticking on here. These are thick insipid secretions in the airways of the patient. So the mucus cannot be mobilized, and therefore there is stasis of the lung secretions in the patient. And due to stasis of lung secretions in this particular patient, you would be noticing the fact that there is mucoviscidosis developing in the patient. And secondary to this mucoviscidosis component, there would be a development of pneumonia. Once the patient is hospitalized, he would be hospitalized not once but again and again, because the problem is very much there. You are giving antibiotics to treat the patient, but the pneumonia component would still much be there. So in all of these cases, you would be having recurrent pneumonia episodes, and because of this recurrent pneumonia episodes in a patient, there would definitely be problems for the patient, because there would be a possible ventilator associated pneumonia that can come in, and two important organisms which are anyway present for this particular case are Pseudomonas and Burkholderia sepaceum. Now please appreciate the fact that once these organisms would come, it will be impossible to manage this case. Most patients of cystic fibrosis in India die before their first birthday because the biofilm will be impervious to antibiotics. In America, however, because they are using tobramycin nebulization right from the time the diagnosis is made, like the baby was identified as having cystic fibrosis early on. So what they're doing is that they're doing a weekly tobramycin nebulization. And this weekly tobramycin nebulization will definitely prevent the colonization of the airways of the patient by these really nasty organisms. And once you prevent the colonization of the airways by these organisms, then the chances of, I would say, bronchiectasis in the patient will be reduced. Otherwise, these patients usually die or can end up with a complication of dilated airways which are filled with pus. These are damaged dilated airways filled with pus. That is called as bronchiectasis. The problems will not be over here because one of the exocrine secretions of the liver is bile. And in this condition, what will happen is that the bile will also be very thick and viscid. So it will be stuck in the liver of the patient. That will contribute to cholestasis. So the next problem that you anticipate in the patient would be obstructive jaundice to develop in the patient, and due to the development of OJ or obstructive jaundice in this particular patient, there would be a possibility of a clay colored stool, a mustard yellow urine, or a bilirubinuria contributing to a dark yellow urine being passed by the patient. These patients on long standing cholestasis will also develop biliary cirrhosis. primary biliary cirrhosis is caused by anti-mitochondrial antibody, but this patient would be having a secondary biliary cirrhosis. The SBC, or the secondary biliary cirrhosis, that is encountered in this particular case is the one which would be responsible for then maybe a requirement for even liver transplantation for the patient, and if the condition is not fit due to pneumonia, he might be denied a transplantation, failing which he will again die. This disease will have ramifications for various organs, and later on the pancreas gets damaged, and even the endocrine component of the pancreas gets damaged. Because of the damage to the endocrine component of the pancreas, the beta cells are also affected in the patient, and due to damage to the beta cells of the pancreas due to insulinopenia, this patient will also develop type 1 diabetes mellitus. And in fact, in these patients, sometimes he might just say the word secondary diabetes because this has been developing secondary to the damage to the beta cells in the patient. The fifth manifestation that will develop in this particular case is based on the fact that the patient will be having, I'm leaving a line here, listen to the explanation. In this case, the pancreatic juice is thick and viscid, and it would be stuck in the pancreas. So therefore the concentration of amylase in the intestine will be relatively lesser. You know that amylase comes to absorb the sugar, and in case the pancreatic juice is stuck inside the pancreas, the availability of amylase in the gut is reduced. So therefore the sugar in this condition will remain unabsorbed, and if the sugar in the gut will remain unabsorbed, therefore this can draw in water and can contribute to osmotic diarrhea. And due to osmotic diarrhea, the child will start losing water as well as nutrients from the body. So the presentation would be FTT, that is failure to thrive. That is explained by the loose motions in this child. He is losing sugar in the stool basically. So instead of writing the word osmotic diarrhea, he might write the word reducing substances in the stool of this patient of cystic fibrosis. Let's have a quick recap at the organs that were involved. It is the gut that is involved initially. The initial presentation of the gut in this case is meconium ileus. But later on, the main manifestation that develops is osmotic diarrhea. That is because of the sugar remaining unabsorbed, since the pancreatic juice would not be available. The lung involvement in this particular case would be that of pneumonia. It could be recurrent pneumonia, and then could be bronchiectasis as a sequelae, though lots of patients in India may not survive up to reach that stage because the disease is obviously necrotizing pneumonia in this case, so the damage would be fairly extensive. Then in these patients, liver can be involved, and that can cause a SBC, secondary biliary cirrhosis in a patient, whereas primary biliary cirrhosis would be due to anti-mitochondrial antibody. Then in these patients, you could also be having involvement of genitourinary system. What I mean by genitourinary system involvement, and that would be the sixth involvement of this patient, would be infertility. The reason for infertility in cystic fibrosis in males would be that there would be agenesis of vas deferens. You have to compare this infertility with that of patients of Kartenegger syndrome. In Kartenegger syndrome, the reason for infertility would be that the dynein arm is defective, so the lashing movement of the tail of the sperm is defective, so the sperm motility is hampered. But in this case, there is a perfect agenesis of vas deferens, due to which even if the sperm motility is normal, it will not serve any purpose. And for females, what happens is that the cervical mucus plug, you see at the 14th day of the cycle, there is a very thin mucus that is paspin barkid basically. In this particular case, what's going to happen is that cervical secretions will be very thick, and they will block the opening of the uterus. So cervical mucus plug, which is formed in this condition, can block the entry of the sperms into the uterus and can contribute to development of infertility in the patient. So genitourinary impact of the disease is presence of infertility. These are some of the important manifestations that can be occurring in cystic fibrosis, and the main reason we are studying it is for two reasons: bronchiectasis and infertility, because bronchiectasis and infertility is also read by you in literature of Kartenegger, but in Kartenegger, as I told you, infertility is found only in male patients, not in females. In females it would be normal, but only in the male patient you will have lashing movements of the sperm being defective. For diagnosis of this condition, sweat chloride has to be used To produce sweat in the patient, the technique used is we apply pilocarpine to the skin of the child. Pilocarpine is a cholinergic compound. It will stimulate the postganglionic fibers of sweating, and therefore once the sweat is produced, it is taken for evaluation of the ions in it, and we go in for a technique called as pilocarpine iontophoresis, where we are checking for the ions present in the sweat like chloride. If the sweat chloride of the patient is more than 60 milliequivalents on at least 2 occasions, we say that the patient is having a possibility of cystic fibrosis. Obviously, the best way to go about this would be to perform genetic studies in the patient. Apart from sweat chloride in this patient, another test to be done, because sweat chloride may not be very accurate. No, like one laboratory said 59 milliequivalent, second said 61. You are stuck. So the next test to be done in this condition is called as TEN, that is transepithelial nasal potential difference test. Apart from TEN, that is transepithelial nasal potential difference test for cystic fibrosis, if he says what is the best way, then the best way would obviously be to identify the gene. And to identify the gene of the patient, we can go in for PCR. So PCR can be done in this particular case. We can go in for evaluation of the deletion 508. In fact, the 1000 mutations in this condition, and that would result in a defective protein, that is CFTR, cystic fibrosis transmembrane receptor, which is gonna contribute to, I would say, the thick secretions in this patient. And once we have done genetic studies, in fact, they might even say the word karyotyping, because chromosome 7 is the one which is defective in this. So obviously, depending on the facilities, we can use these in the following order. Best would be obviously genetic studies to be 100% sure. And for management of this condition, we don't have any definitive treatment, though much importance or much improvement has been done in recent time with respect to a new drug for this condition, which should be remembered as ivacaftor. This drug basically affects the secretions, which are the main problem of this disease, that the thickness of the secretions are becoming lesser, so therefore the chances of stasis of secretions would be significantly reduced. The main focus, I'll come back to the previous slide, would be, and I'll just summarize that for you. Whenever you read a multiple choice MCQ with bronchiectasis, which is also talking about infertility, you have to be careful to see that whether the infertility component is given in both the genders, or whether the infertility component is given only for a male patient, because infertility in both genders is a feature of cystic fibrosis, whereas only for a male patient is a feature of Cartenegger syndrome. In both of the conditions, he will deliberately mention recurrent sinusitis. He will mention regarding bronchiectasis in a patient anyway, and the feature of dextrocardia may or may not be given in the particular question, because that will make it very easy for you. If you read dextrocardia, obviously it is Cartenegger syndrome in a patient, but I just want this particular aspect to be clear to you. In cystic fibrosis in a male patient, the reason for infertility would be agenesis of vas deferens, whereas for a female patient, it will mostly be a cervical mucus plug. When I describe this, a lot of guys send queries saying that why not in a female patient of Cartenegger syndrome, would her cilia not be functioning in the fallopian tube? I agree that in a female patient of Cartenegger syndrome, the cilia will not function properly. But remember that the motility of the ovum in the fallopian tube is not dependent on the cilia only. It is dependent on, I would say, tubal peristalsis, and tubal peristalsis is the main parameter that decides the motility, so that the fertilization can occur in the ampulla. So in female patients, even if the ciliated columnar epithelium is malfunctioning, the tubal peristalsis will take up for this. Another aspect to be remembered from this discussion is ABPA, that is allergic bronchopulmonary aspergilloma, which is going to be responsible for central bronchiectasis. The organism responsible for this one is Aspergillus fumigatus. Do not answer actinomycetes, which is responsible for bagasosis in a patient or for farmer's lung in a patient. There is colonization of the airways of the patient, due to which the patient will come to you. He is a known asthmatic, let me say. Asthma patient has come to you with complaints. He says, doctor, I don't know what's going on. I am having black sputum plugs, and that looks very scary, black sputum plugs in an asthmatic patient. When I evaluated this chap, obviously his immunoglobulin E was elevated. I noticed his eosinophil count was maybe on the higher side, because he's an asthmatic, so all these changes related to allergy would be present. I also got a sputum culture done of this guy, and the sputum culture was positive for fumigatus. But the problem is that though fumigatus has been isolated from the sputum of this person, I want you to remember that fumigatus can be present in airways of normal people also. Now, if something is present in airways of normal people and is cultured from this particular person, I cannot say that this is a major diagnostic criteria. So sputum culture cannot be used as a major diagnostic criteria. Why? Because this organism can be found in airways of normal patients also. Fumigatus can be isolated in airways of normal people also. So to diagnose this condition, which is a hypersensitivity, the test that we will do will be called as serum precipitins against the Aspergillus species. This in combination with a CT scan finding, which will show central bronchiectasis, that is mainly the middle of the lung is involved. The dilated airways are mainly the middle part of the lung, is what is the main clinching point for the diagnosis of this condition. In allergic bronchopulmonary aspergilloma, on reading the word Aspergillus fumigatus, don't straight away start talking about fluconazole and amphotericin B. We will give it, but initial manifestation of this patient is steroids to reduce the hypersensitivity reaction to the fungus, and later on antifungal drugs are used to decrease the colonization of the airways of this person. A very surprising discussion, but should be remembered anyway. Do not mix it with thermophilic actinomycetes, because that would be with respect to farmer's lung, or thermophilic actinomycetes would be with respect to a condition by the name of bagasosis. You know that in bagasosis there would be sugarcane dust. In the exam he has asked that what fungus is growing on the surface of the sugarcane dust, the inhalation of which will result in patient having development of hypersensitive pneumonitis and development of breathlessness. So in both of these conditions, the fungus that is involved, in farmer lung, the surface of the hay is dried grass, which would be having this fungus, and on sugarcane dust also the fungus that would be growing is thermophilic actinomycetes. This thermophilic actinomycetes is the one, the fungus I'm talking about. This is the one which is responsible for development of bronchospasm in these patients on exposure. So this farmer, he walks into a barn. Barn is an area where dried grass is kept and he starts feeling suffocated. Or this sugarcane industry worker, he starts feeling suffocated. So bronchospasm on exposure would be occurring in these particular patients of this antigen that would be the fungus. Therefore, the term that we use to describe this manifestation is called as hypersensitivity HP, hypersensitivity pneumonitis. This disease is an example of type 4 hypersensitivity reaction. In older books, it was called as type 3 hypersensitivity, but currently this is an example of type 4 hypersensitivity reaction. It would cause a development of significant bronchospasm on exposure to the antigens. And also another term used for hypersensitivity pneumonitis would be non-asthmatic. We will say non-asthmatic because there is no histamine, that is the villain. The alternative term for this is called as non-asthmatic. The reason why we call it non-asthmatic is because leukotrienes are not the villain here. Histamine is involved, agreed, but at least in this condition we are not having any presence of, I would say, leukotrienes. So non-asthmatic extrinsic allergic alveolitis is the terminology that we use for this. That's an alternative term for hypersensitivity pneumonitis. And if you do a bronchoalveolar lavage in this patient, that would be showing presence of lymphocytes, not eosinophils, right? So bronchoalveolar lavage would show lymphocytes to be present in this condition. And the best way is obviously avoidance of exposure to the antigen. But if not, then in those circumstances, we will have to use steroids for management of this patient. So two conditions where actinomycetes is to be answered is what I've told you. And for ABP, it's obviously fumigatus with central bronchiectasis, plus this is the slide which I have mainly wanted you to focus on. I would like to remind you the fact that tree in bud appearance is a feature of endobronchial TB and pneumocystis jirovecii pneumonia. And now we go on to our next slide, which was given without any history, and will a pretty close image, because one of my students said that he just looked at the markings here. You see the markings here are themselves saying CT pulmonary angiography, CT angiogram pulmonary circulation. The moment you read that, you can see that this is the main trunk of the pulmonary artery. This is obviously the aorta. This is also the aorta. This is descending aorta. This is ascending aorta. And then you can see a very big embolus, a big embolus here. This embolus is like a saddle embolus, I would say. It is sitting at the bifurcation of the pulmonary artery of the patient and therefore is contributing to pulmonary thromboembolism. The saddle embolus is responsible for pulmonary thromboembolism in the patient. What you have to remember for this medical condition is that there should be either a deep vein thrombosis present in a patient, or there could be a malignancy present in a patient, especially in the setting of deep vein thrombosis, especially in setting of malignancy, because malignancy is a hypercoagulable state. Or he could mention prolonged immobilization in a patient, like this person was crossing the road, he had a bumper fracture. Or he could mention patient undergoing implant surgery like THR, TKR. In all these patients, in the settings that I have mentioned here before you, there will be a development of sudden onset distress in the patient. The chest pain that is experienced by this patient is a pleuritic chest pain. In fact, I'm writing it like this only. There would be a pleuritic chest pain developing in the patient. And on examination in this person, you will be having tachycardia. Blood pressure will begin to become lesser because blood supply to lungs would be lesser, so automatically the blood supply to left side will also be reduced. And the auscultatory finding of the patient would be a wide split second heart sound, which will mostly be of the fixed variety, because in this case, why I'm saying fixed, because traditionally I've talked about fixed for ASD, because the thrombus will not decide how much blood will go in the lungs. I mean, pathology will override the physiology, so the pathology will decide how much blood will go in the lungs of this guy. Because of the deterioration of this particular patient, you will have to do a quick workup. Both lungs are clear in this condition. Why clear? Because there is no pulmonary edema in this condition. Pulmonary edema is a feature of left ventricle failure. This patient is having a right ventricular failure, so bilateral lungs are clean. For the screening for this particular case, you will be doing a D-dimer assay. Fibrin degradation products FDP is to be answered as a screening test for DIC. I repeat my statement, for DIC do not answer D-dimer, answer fibrin degradation product. For this pulmonary thromboembolism, answer screening as D-dimer assay. In the ECG of this particular patient, if he says what is the ECG finding of pulmonary embolism, the answer would be given as sinus tachycardia. But if he gives you a scenario of a massive pulmonary embolism, only then you will answer the classical term S1Q3T3, which is deep S waves in lead 1, deep Q waves in lead 3, and inverted T waves in lead 3. In the chest X-ray of this particular patient, if he says pulmonary embolism, the answer would be given as normal. But if he specifies the word massive pulmonary embolism in a patient, only then you will remember the classical term for the X-ray for which I've shown you earlier, that is in the form of a Hampton hump. For treatment of this particular condition, if he says the way he has given this saddle embolus and he says what is the treatment for saddle embolus, obviously the manifestation will be massive pulmonary embolism in a patient. Massive pulmonary embolism is treated by thrombolysis. The thrombolysis which would be given in this particular case would be L-teplase, that will dissolve the clot and therefore the patient will definitely recover. But if the question is asked as what is the treatment of choice for PE, that is pulmonary embolism, then we can be giving heparin to the patient. If the word is plain PE, then heparin is the treatment. The heparin that can be given, one is low molecular weight heparin to the patient, that is enoxaparin short can be given subcut. And the second way is obviously to give unfractionated heparin in a patient, which is given in the form of a drip. It is better to give a unfractionated heparin drip because it's easier to manage and the effects can also be controlled as compared to a single shot or low molecular weight heparin, which is given once a day. Though some authorities recommend once a day, some authorities mention a drip format. So their textbook has not given a clarity, but in Harrison he has mentioned that better control, the word has been mentioned, that better control is with plain heparin drip. So it is low molecular weight heparin which will be better for prophylaxis of this condition. And if he says how do you prevent pulmonary embolism of the massive variety or the routine pulmonary embolism in a patient, then one, you can go in for compression stockings. which can press on the legs of this particular individual and will prevent the clots from developing, because the compression stockings are powered by air pump, so they'll compress the legs of this guy, and therefore the chances of clot formation will also be lesser. And second, we shall be giving low molecular weight, ultra low molecular weight, in fact ultra low molecular weight heparin shots would be given to the patient. So enoxaparin is low molecular weight heparin and fondaparinux is ultra low molecular weight heparin. So we can use these molecules to prevent pulmonary embolism from developing in a patient. The image here shows the saddle embolus, as I showed you, and the management process of which is one that I have discussed. Okay, coming to the next X-ray, guys, I want you to appreciate the fact that in one of these images, the first one, you will notice an extremely convex fullness present in the pulmonary artery segment. This patient is actually having a pulmonary artery hypertension, and that would contribute to exercise intolerance. So if the first X-ray would be given to you, even without a history, you should be able to crack and appreciate the pulmonary artery fullness. But most of the time, he will describe a person with exercise intolerance, because pulmonary artery hypertension need not be only due to diseases of the left side of the heart. It can be idiopathic also. It could be due to drug intake also. So exercise intolerance is one of the presentation of pulmonary artery hypertension, primarily because of the fact that the blood supply to the lungs would be lesser, because if pulmonary artery pressure is higher, the right ventricle will not be able to push blood into the lungs of the patient. The auscultatory finding that could be given in this particular patient could be loud P2. There's a fullness of the pulmonary artery segment on X-ray. The auscultatory finding of this patient would be a loud P2. That's because the higher pressure will contribute to the pulmonary artery slamming with more force. The pulmonary artery hypertension can also cause a pulmonary regurgitation, so that could result in an early diastolic murmur to develop in the patient. Most of the time, because of the fact that there is a pulmonary artery hypertension, the right ventricle of the patient also begins to fail. We call it a functional. Due to pulmonary artery hypertension, the patient will also have failure of the right hand side, and due to dilatation of the right ventricle, there will also be dilation of the tricuspid annulus, which will result in a functional tricuspid regurgitation in a patient. I'm calling it functional because as such there is no damage to caudate antennae or to the valve apparatus, but because the right ventricle will dilate, the tricuspid annulus will also dilate, and therefore blood would be able to leak from the RV to the RA of the patient, contributing to a functional TR, and the murmur would be that of a pansystolic murmur. The findings of pulmonary artery hypertension can be a loud P2. If the pressure increases further, the early diastolic murmur of PR will develop. If the right side of the heart will decompensate, then a functional TR can also appear in the patient, and obviously the symptoms of exercise intolerance will worsen in the patient. Definition of pulmonary artery hypertension should be known to you. You know that the normal pressure in the pulmonary artery of yours and mine, systolic is 25 and diastolic is 10. The mean pressure of the pulmonary artery for you and me is about 15 millimeters of mercury. That would be calculated by systolic plus 2 times diastolic, whole thing divided by 3. So if you put the values of 25 by 10, you can work out the value of 15. Pulmonary artery hypertension is defined as pressure more than 25 millimeter of mercury at rest, or would be defined as more than 30 millimeters of mercury on exertion. The investigation choice for pulmonary artery hypertension would be cardiac catheterization. Now, if the facility of cardiac catheterization is not available, obviously echocardiography can be used. We can switch on the Doppler, we can measure the pressure values, we can check for the murmurs as well. For treatment of pulmonary artery hypertension, the drug of choice should be answered as ambrisentan. Apart from the ambrisentan perspective, even bosentan can be used. Though initially for management of pulmonary artery hypertension, the first line drug that we usually introduce for pulmonary artery hypertension patients would be calcium channel blocker amlodipine. But if patient is having progressive dyspnea, then we might have to add to the patient phosphodiesterase 5 inhibitors like sildenafil or tadalafil. And if patient deteriorates even further, then we will have to add bosentan or ambrisentan. And if he goes into stage 4, then in those circumstances, we will have to add for this particular patient, or we'll have to give to this patient prostaglandins. We will be giving intravenous prostaglandin to the patient by the name of epoprostinol. Or another prostaglandin that would be given to the patient would be, normally you see prostaglandins we use for induction of abortion and cervical ripening at the time of labor, but here we are using prostaglandins intravenously for pulmonary artery hypertension. And inhaled prostaglandin which is available now is by the name of Eloprost. This is the inhaled version which would be used for management of the patient. So this would be NYHA, New York Heart Association grading of dyspnea, and we will be treating our patients of pulmonary artery hypertension based on the NYHA grading. And remember the fact that for PAH, the pulmonary artery segment will become extremely convex. You can even notice the pulmonary artery segment of the contralateral side also being very, I would say, prominent. In fact, these are all pulmonary vessels which are contributing to the extreme increase in the vascularity of the lung on this particular side. And then there could be a concomitant lung infection which could be present in the patient, which could give an appearance like this. Even on the contralateral lung, you can notice the pulmonary artery segment being fairly, I would say, prominent, and even the cardiothoracic ratio of this patient is increased. There's definitely a cardiomegaly in this patient, so it could be that left heart disease could have resulted in a pulmonary artery hypertension in the patient. I would like to highlight the fact that normally on a chest X-ray, when you look at the aortic knuckle, below the aortic knuckle, there is a concavity always. There's a concavity of the pulmonary artery segment, but in this case, the pulmonary artery segment is very full. Then you will notice in the next image, in this case the history given is that of a person with daily headaches. This is a hypertensive patient, and in the hypertensive patient in the chest X-ray, two things have been highlighted. One is that the person is having inferior notching of the ribs, and the second that you can see is the presence of a 3 sign. This 3 sign is mainly in the area of the aortic knuckle, that is in the upper part. So the 3 sign is occurring here. The 3 sign is occurring here. There is the pre-stenotic segment that is dilated. The pre-stenotic segment of the narrowing of the aorta is causing the pre-stenotic part of the aortic knuckle to get dilated. And all of these findings together, that is hypertension, inferior notching, and a 3 sign, they all point towards diagnosis of coarctation of aorta in a patient. They can also ask you that why is there an inferior notching of the ribs. The reason for this can be understood like this. Like suppose this is the representation of the ribs of the patient. This is another rib. Below the ribs are arteries which are called as intercostal arteries, and what happens in this disease is that these intercostal arteries, they would be working like collateral. So I've shown a dilated tortuous intercostal artery, and now what I've done is that I have highlighted that this dilated tortuous intercostal artery is so dilated and tortuous that the pulsations of the artery will be transmitted to the inferior border of the rib. Therefore, due to the pulsations of the artery directly being transmitted to the inferior border of the rib, there would be a development of notching of the ribs of this particular individual. That is the main reason why, I mean, in coarctation of aorta, you get inferior notching of the ribs. The routine presentation of coarctation of aorta would be that patient would be having claudication, that is pain in the legs on walking, which may or may not be given in the history. But yes, hypertension would come up in the patient. Why? Because there would be a presentation of increased peripheral resistance. Then this person will give you history of wearing woolen socks in summer season. The person says that my family members, they make fun of me because I wear woolen socks in summer season. Why? Because the blood supply to the toes is very less, so therefore the toes are icy cold in a hot Indian summer, and the person is wearing woolen socks. Differential cyanosis, guys, may not be very visible, no, because we Indians are relatively dark skinned as compared to Americans, so we may not be able to appreciate in the patient. In fact, you may not be able to appreciate the differential cyanosis component. Because of hypertension, left ventricular hypertrophy will set in, and angina will also occur in the patient. In the MCQ, you have to differentiate this presentation from that of aortic stenosis, which would be syncope, angina, and dyspnea. SAD is the mnemonic for aortic stenosis. Here it is claudication, hypertension, and woolen socks in summer with LVH. LVH will cause angina. On examination in this patient, if radiofemoral delay is given in the question, this question will be a piece of cake for you. So most of the time they will not give this to you. Rather, they will mention regarding differential cyanosis, where the toes are blue and the fingertips are pink in the patient. Or instead of asking you about differential cyanosis, he can mention regarding the continuous murmur, which is encountered in this particular patient. That's because of the collaterals which are present. Then the BP in this guy in the upper limb, will be more than the BP in the lower limb, whereas in a normal person BP in the legs is higher. Here it is reverse, the BP in upper limb will be higher in this person. Then in these patients, when you do a workup, the investigation of choice would definitely be a MRI of the aorta. That's the investigation choice. The X-ray findings are two, which I have highlighted before you. One is the 3 sign. The reason for the 3 would be the pre-stenotic dilatation of the aorta. Most of the time the aorta is dilated proximal to the obstruction. And what is the site of coarctation of aorta? Then the most common site of coarctation of aorta is that it is just distal to the origin of the left subclavian artery. This would be unofficially the starting of the descending aorta. I've written distal to origin left subclavian, so that would be starting of the descending aorta. That's where it is present. So wherever the narrowing is present, the proximal, like suppose it is like this, right? This is the stenosis. So over a period of time, the pre-stenotic part gets dilated in the patient, and therefore these manifestations would be encountered. For management of patients of coarctation of aorta, if he says, for what would you do for high blood pressure, your answer should be remembered as balloon dilatation with stenting. Yes, we can do balloon dilatation for heart, we can do balloon dilatation for aorta always, and stenting would be done. I mean, if we have the technology to go into the coronary artery and do stenting, doing stenting of the aorta is obviously no big deal. Two very closely matching X-rays have been shown to you where the findings are mainly restricted to the left side of the heart in the patient. And suppose you are stuck in a question where you're not able to identify whether should I answer pulmonary artery hypertension, should I answer coarctation of aorta, what will you do? You will look for the pulmonary artery hypertension versus systemic hypertension profile of the patient. Pulmonary artery hypertension profile will be exercise intolerance. Systemic hypertension will cause daily headaches and angina and chest pain in the patient. And suppose there is no history given for pulmonary artery hypertension or systemic hypertension, then what will you do? Look at the inferior border of the ribs of the patient. And lots of time, like in this one, right? We all work in government hospital, guys. The images may not be of very good quality, in a sense that you may not be able to appreciate the exact inferior notching of the ribs in the patient. To a radiologist, to a trained eye, yes, he might say that yes, because the inferior border of the lips look relatively more whitish and looks more serrated, right? So that serration, or that I would say irregular appearance of the lower border of the rib. In fact, 3 ribs are definitely showing that. So if you've seen something like this earlier, you may be able to appreciate it. But even if you are not able to appreciate the inferior notching of the ribs of the patient, still clinical history would do the trick. If not, then obviously you will have to rely on some of your gut feeling, because sometimes I would say that these x-rays might look very close, though I've tried to give you extreme differentiation between the two. If stuck in a question like this, and systemic hypertension and pulmonary artery hypertension is also not given, then try to look for the notching of the ribs. And still, if you're not able to pick it up, then answer it as pulmonary artery hypertension, because most of the time the question that will come to you will be having exclusively that pulmonary artery segment, which is very significantly elevated. Why I'm saying is, in this x-ray, I cannot call it a classical 3. I cannot call it a classical 3. You can see, I mean, this doesn't look like alphabet 3 anymore. So if this is the kind of image given, then obviously pulmonary artery hypertension has to be answered without history, I'm saying. With history, obviously, if you remember the information of the slide, then things should become relatively simpler. Moving to the next one. As I said, the serrated appearance of the ribs, or the irregular appearance of the ribs, is something that has to be remembered. So figure of 3 sign is a feature for coarctation of aorta in the patient. The next aspect, guys, that I wanted to remember is a question from the NEET exam, where they said that in a marriage party, people ate crab meat, and after ingestion of the crab meat, few weeks later, a lot of villagers, they started having hemoptysis, that is blood in the sputum. Now they say that this is a village in coastal India where eating seafood and crab meat is routine, and the persons in the village are having hemoptysis. Then you can understand the fact that I'm talking about lung fluke. The image shown here is that of a lung fluke, that is Paragonimus westermani, and this would be secondary to the intake of poor quality crab meat. Hemoptysis is something which anyway has to be remembered from the lungs perspective that we have just revised. When it comes to the aspect of hemoptysis in a patient, overall the leading cause is tuberculosis only. Even if he changes the question into that of massive hemoptysis and says what is the leading cause of it, the answer is still TB. The source of bleeding in this case will be the bronchial artery of the patient. You see, bronchial artery is a relatively thin-walled vessel as compared to pulmonary artery that has a lot of connective tissue. So, tuberculosis bacteria can damage the bronchial artery, they can damage the pulmonary artery, but the issue is that the pulmonary artery has a lot of connective tissue. So, you can notice that I have not shown any rupture of the pulmonary artery of the patient. I've shown mainly the rupture of the bronchial artery of the patient, which is relatively thin-walled and has less connective tissue. So the aneurysm that develops in the pulmonary artery was asked in your exam, and that would be called as Rasmussen's aneurysm. The question to be remembered is Rasmussen's aneurysm is encountered in TB in which blood vessel? Pulmonary artery. Whereas bronchial artery, having relatively less connective tissue, is more vulnerable to rupture and therefore will trigger massive hemoptysis occurring in a patient. Then they have asked regarding spurious hemoptysis. Spurious hemoptysis would imply that the secretions will be pinkish red in color. This would be due to a bacteria that can produce pinkish red secretions, that is by the name of Serratia macerans. This organism is also read by you in pediatrics for causing pink diaper syndrome. The urine of the child will be having a pinkish tinge. Even if that notice, when it will stain the diaper, the mother will notice. So pink diaper syndrome is related to Serratia macerans. Then they have asked regarding endemic hemoptysis, which I've already told you, Paragonimus westermani. But if he says recurrent hemoptysis in a patient, then for recurrent hemoptysis, the answer should be given as bronchial adenoma. Do take care of the fact that recurrent hemoptysis is usually occurring from bronchial veins. Then he might ask you cardiovascular cause of hemoptysis. Normally we study regarding lung causes of hemoptysis, that could be like bronchiectasis, Wegener's granulomatosis. Even sometimes you might be having lung abscess patients might be having erosion into a artery, but cardiovascular causes of hemoptysis will mainly be mitral stenosis and left ventricular failure, where the increased pressure of the bronchial veins will be transmitted to the pulmonary veins, and the bronchial veins are relatively thin-walled, so actually they are the ones which will rupture. But then cardiovascular causes of hemoptysis to be remembered are mitral stenosis and left ventricular failure. Then you will read about hemoptysis in a MCQ Good Pasture also, where the MCQ will talk about combination of the two, hemoptysis with hematuria. This is because the antibodies will be damaging the collagen in the wall of the blood vessels of the kidney as well as of the lungs. So hemoptysis with hematuria is a presentation that is encountered in Good Pasture syndrome. But if the question starts talking about hemoptysis also, epistaxis also, instead of talking about epistaxis, he might say recurrent sinusitis, but because I'm talking about bleeding, epistaxis, and then says hematuria, then you can notice the fact that in this one, I have talked about bleeding from the lower respiratory tract, bleeding from the upper respiratory tract, and obviously the kidney involvement. 3 things in contrast to 2 things on the top. So combo of the 2, hemoptysis with hematuria, is obviously Good Pasture. But Good Pasture is not going to have a epistaxis or recurrent sinusitis. So this is definitely going to be a different disease. Though I've now given you the pointer here also, that is C. ANCA is present in this particular patient, the inferior patient I'm talking about. But even if C. ANCA is not given, I want you to be able to pick up the diagnosis, that is Wegener's granulomatosis. Wegener's granulomatosis as a disease name has been removed from the textbook of internal medicine, and nowadays the word used is granulomatosis with angiitis. That's the same WG, Wegener's granulomatosis, that we used to read earlier, but now the term has been replaced by an alternative term, that is granulomatosis with angiitis, where the investigation of choice or antibody test will always be given in questions. But even if not given, you should be able to pick up the fact. 2 aspects I've said: hemoptysis with hematuria, hemoptysis. Epistaxis hematuria is granulomatosis with angiitis. That condition has strawberry gums also, but even if I am saying strawberry gums is again very classical, no further disease. I'll show you the picture of strawberry gums in a while, but strawberry gums, even if not given, you should be able to pick up granulomatosis with angiitis in a patient. Then he'll ask you what is the test to be done for hemoptysis. Like a patient has come to you, he's having blood in the sputum. Obviously, I will do a chest X-ray, but X-ray may not be able to localize the lesion in this condition. So, HRCT will be the first line investigation for localization of the lesion. That is, I will be able to know whether the lesion is left-sided, right-sided, upper lobe, lower lobe. So, I can localize it. Then is the investigation of choice for this condition. That would be obviously to go inside, send in a camera, and then evaluate where is the lesion present. That is a flexible fiber optic bronchoscopy. Remember my words, always answer flexible bronchoscopy except for massive hemoptysis. If he specifies by saying massive hemoptysis, which is defined as blood loss more than 500 ml, then it is to be answered as rigid bronchoscopy. But if he specifies the word hemoptysis only, then it is a flexible fiber optic bronchoscopy, and the treatment of choice for hemoptysis would be a cautery, a bronchoscopic cautery. We can do a bronchoscopic ligation, we can do a bronchoscopic cauterization of the bleeder, and therefore the patient will definitely be best treated. Otherwise, obviously, surgical options are also there, but bronchoscopic cauterization is a non-invasive method by which we can aggressively treat this particular category of patients. I also want you to remember the drug of choice for Paragonimus westermani, which happens to be praziquantel, though some authors or some books are mentioning triclabendazole also, but as compared to triclabendazole, which is not approved in USA and is also having a less efficacious response, the best treatment for Paragonimus westermani should be answered as praziquantel. Okay guys, the next topic that we will revise is ARDS. I am giving you a scenario of respiratory distress developing in an individual after a blood transfusion. It is like the patient received massive blood transfusion and subsequent to that he's having TRALI, that is transfusion related acute lung injury, which happens to be one of the important causes of death in patients who have had a massive blood transfusion. So not only can you be getting ARDS with respect to aspects like swine flu or bird flu, the incidence of which have increased dramatically, but it would also be seen with septic shock where the cytokines would contribute to it. Then aspiration of stomach acid or Mendelssohn syndrome is responsible for development of acute respiratory distress syndrome in a patient. The next cause which is responsible for development of ARDS could be pulmonary contusion, or could be like I gave the scenario above of a massive blood transfusion which would result in TRALI, that is transfusion related acute lung injury, or it could be scenarios of acute pancreatitis. So if any of these examples are given to you and then he mentions the fact that there is a sudden deterioration of the patient, then you have to think in terms of acute respiratory distress syndrome. Nowadays they don't use the word acute lung injury, but they have started grading ARDS as mild, moderate and severe. So before we look at what's going to actually happen to the patient, let's quickly revise the grading here, which is based on the value of PaO2 FiO2 ratio, that is partial pressure of oxygen divided by fraction of inspired oxygen, which would be for room air 20%. If you are encountering a question in which the value is between 200 to 300, we will be calling it mild ARDS. Values between 100 to 200, that is moderate, and for the severe variety, obviously it would be less than 100. So acute respiratory distress syndrome is best diagnosed on the basis of a PaO2 FiO2 ratio with pulmonary capillary wedge pressure remaining less than 18 millimeters of mercury, and obviously there should be an inciting event or an insult in the patient. So let's work it out quickly. What's going to happen to the patient in the following scenarios? In all of these conditions, there would be cytokine induced damage to the alveoli of the lung, so the alveoli will collapse. Therefore, the manifestations of the disease would be that patient would be having pulmonary edema, but since heart is not involved in this condition, directly lungs are involved, the X-ray is going to be in the paper as white as you can think of, like you can hardly see the lung parenchyma. So there would be a non-cardiogenic pulmonary edema developing in the patient, extensive pulmonary edema developing in the patient, but in the setting of pulmonary capillary wedge pressure being less than 18 millimeters of mercury. In this condition, even if you give 100% oxygen to the patient, there is going to be no improvement in the general condition of the patient. Why? Because the alveoli are collapsed and they're filled with fluid, so there is a refractory hypoxia. There is wastage of blood going in the pulmonary artery segment because now the hypoxia will cause constriction of the pulmonary arteries. So therefore, the term that is used for the wastage of blood and less oxygenation is called as intrapulmonary shunting, that wherever there is a collapsed alveoli of the patient, the blood vessels are also constricted. So intrapulmonary shunting will cause worsening and deterioration of the patient. It's an unending cycle. Now alveoli collapse, pulmonary vasculature collapses, more hypoxia, more alveoli will collapse. So this keeps on deteriorating this particular patient. Therefore, in these patients, you will have to grade them on basis of PaO2 FiO2 ratio. If less than 300 is diagnosis of ARDS, and once that happens in a patient, you will have to then do a workup of these patients. In workup of these patients, you will notice that initial presentation of this patient would be hyperventilation and there would be a development of washout of carbon dioxide. But gradually, as the VP shunt mismatch will worsen, then respiratory acidosis will start developing in this patient. So the ABG of this person on initial presentation, when he presented to you initially like a swine flu patient having hyperventilation, they might be type 1 failure. But in the later phases of the disease, when the ventilation perfusion mismatch will be very significant in the lungs of the patient, then carbon dioxide can't be excreted because pulmonary vasculature is collapsed. So it's a dynamic state. The patient will subsequently develop carbon dioxide narcosis and respiratory acidosis, and that is what happens in most lung diseases. Acute asthma deteriorates into severe acute asthma. Initial presentation of fat embolism can be hyperventilation, but whenever there is a alveolar collapse in a patient, there is a VP mismatch, then respiratory acidosis will ensue. So all lung diseases finally deteriorate into respiratory acidosis and type 2 respiratory failure. When you will be doing a chest x-ray of this particular individual, you would be having extensive bilateral infiltrates present. So though in a routine discussion I've tried to tell you that the heart size would be normal, but here you can't appreciate the heart size. Look at this x-ray. I mean, you just can't evaluate the size of the heart because the whiteness is so confluent. Bilateral confluent pulmonary edema is developing in this patient. So bilateral infiltrates is what I've said here. And finally, for these patients, we will have to treat them on the basis of what is called as low volume ventilation. The preferred ventilator modality for patients of ARDS is low volume ventilation. If you are gonna use the standard ventilation approach, it might result in barotrauma and a pneumothorax in the patient as well. So these are some of the important aspects that I want you to remember, especially like the treatment of choice should not be answered as intermittent positive pressure ventilation or high frequency jet ventilation, but low volume ventilation should be used for management of this patient. Trauma to chest can result in even a development of ARDS in the first 24 hours. Now, trauma to the chest can also result in development of a hemothorax, and trauma to the chest can also result in development of a flail chest in an individual. So whenever a question begins like this, that the person had trauma to chest or patient had polytrauma and patient is having now development of respiratory distress, the answers in the question will vary. If the question begins by saying that the respiratory distress has started after 24 to 48 hours of the actual trauma, the trauma has not started immediately but has started after 24 to 48 hours, especially polytrauma present in a patient. Polytrauma implies even humerus can be fractured and even there could be like fracture of the femur. Then you have to think in terms of fat embolism syndrome or FES in the patient, which is diagnosed on the basis of GERD criteria, GURD, GERD criteria. But if you read about respiratory distress in a patient, which is developing usually in the first 24 hours only, one possibility to be obviously kept in mind would be flail chest, because if the ribs will fracture, obviously he will be having chest pain and difficulty in breathing. Another possibility can be hemothorax in a patient, where you will notice blunting of the CP angle of the patient. And then third but not the least also to be remembered is trauma to the chest can trigger a ARDS also. So I've given you 3 x-rays. This one is obviously showing a fracture of the ribs, which is very obvious. You can see these fractures. So flail chest present in a patient. The history in this case is of trauma to the chest, and there is a definitive, I would say, hemothorax present in the patient. You can notice the blunting of the CP angle and extensive amount of blood present in the chest of the patient. And third possibility is the X-ray that I just showed you, that is that of ARDS in a patient. So these are some possibilities that I want you to remember for respiratory distress to develop. If respiratory distress is present after a central line insertion, the preferred site for central line is subclavian vein, where it meets with the superior vein cava. Respiratory distress present in a patient after central line insertion, then the diagnosis is to be thought of as pneumothorax in the patient. However, if the respiratory distress is developing usually on day 2 of a pelvic surgery, or of a orthopedic implant surgery like total hip replacement, then you have to think in terms of a pulmonary thromboembolism present in a patient. On the other hand, if there is respiratory distress with presence of chest pain in a patient, presence of excessive sweating in a patient, then you have to think in terms of obviously a myocardial infarction. These are some scenarios for respiratory distress that have been given in various situations, and especially for the first one, I would like to say the fact that the symptoms don't develop immediately, they take some time to appear. So fat embolism syndrome, the aspect of GERD criteria, where there would be CNS manifestation like coma, there would be lung manifestation like distress, there could be petechiae all over the body of the patient, there could be saliva containing fat globules, there could be urine containing fat globules. So when those criteria or features are present, then obviously fat embolism is to be considered in the patient. But these are a couple of scenarios for respiratory distress that has to be taken care of. Then we will have a quick revision of the types of respiratory failure, which are subclassified as 1, 2, 3, 4. Type 1 respiratory failure is obviously hypoxia, but there is less of carbon dioxide. The less carbon dioxide is primarily due to the fact that the patient would be having hyperventilation, whereas in type 2 it is buildup of carbon dioxide. Conditions like pneumonia, conditions like fat embolism, they can initially trigger type 1 respiratory failure in a patient because patient would be having hyperventilation. But when it comes to type 2 respiratory failure in a patient, one of the example of that can be traditional answer of status systematicus, or he can give you a scenario of a very fat person who's having fat even around the alveoli, which are impeding the transportation of gases, that is Pickwinian syndrome. Or he could give you scenario of Guillain-Barré syndrome, transverse myelitis, where there is a diaphragmatic paralysis in the patient, or myasthenic crisis in a patient where there is a diaphragmatic paralysis in a patient. So hypoventilation states would be having type 2 respiratory failure. But when it comes to type 3 respiratory failure in a patient, it will always be post-operative. Type 3 respiratory failure is always a post-operative atelectasis, where in the patient, due to continuously lying in the supine position, there would be hypoxia developing. The best way to manage this is to advise the patient to go in for incentive spirometry. That is, you would be having this instrument in which various color balls are present, and the patient is encouraged to blow into the mouthpiece so as to lift the balls in the device. Incentive spirometry is very good for management of post-operative atelectasis, and in fact the question in the recent AIMS exam was that a post-CABG patient is having severe respiratory distress. What is the cause? You see, in coronary artery bypass grafting, you obviously have to, even if you do minimally invasive, no, you still have to open up the chest and get access to the heart. So because you're opening up the chest wall of the patient, so most of the time the reason for respiratory distress that will develop after post-CABG would be a respiratory failure in the patient, and that is why we always encourage extensive exercises of the chest wall before the person is subjected to a CABG surgery, so the muscles in the chest are in sharp shape and the recovery can be relatively faster. For type 4 respiratory failure, it is the problem with blood supply to muscles of the respiration. There is an underperfusion of the muscles of respiration. So underperfusion of respiratory muscles can occur due to conditions like shock, which could be like cardiogenic shock, obstructive shock, where the blood supply to vital organs is maintained and respiratory muscles are not getting perfect oxygenation. Why type 4 has been kept different from type 1 is in type 1 the problem is in the lung parenchyma, and in type 4 respiratory failure there is a fatigue of the muscles because they're not getting sufficient supply. So for type 4, because muscles will fatigue due to lactic acidosis, there would be a ventilator requirement for the patient. Whenever there is a deterioration of the patient to the level that muscle fatigue will set in, always a patient has to be subjected to a usage of a ventilator so that the possibility of deterioration in the patient can significantly be reduced. Carbon dioxide narcosis can also result in development of asterixis. In fact, 3 causes of asterixis that can be remembered by you are carbon dioxide narcosis, hepatic encephalopathy, and uremic encephalopathy are causes which are responsible for development of asterixis in a patient. The 4th I can give you is for all except MCQs, thyrotoxicosis of pheochromocytoma. Thyrotoxicosis would rather be having presence of fine tremors in the patient. The 3 conditions will cause a negative myoclonus, that is asterixis. Negative myoclonus means sudden decrease in tone of the muscle. So there's a flap movement of the hand of the patient, whereas thyrotoxicosis will be responsible for fine tremors of the hands of the patient. And then there was also a question regarding which tremors will improve with alcohol intake. So tremors that reduce with alcohol intake. A weird statement. Alcohol intake results in development of decrease of which variety of tremor. So that would be called as essential tremors. You see, some of us can be having an increased adrenergic drive, and that could result in essential tremors. People who have essential tremors, if they want to go into surgery, that would really not be a very good idea. And obviously, consuming surgery after alcohol intake is only where movies like Kabir Singh can show. Otherwise, normal people don't operate under the influence of alcohol. So crazy things shown in movies nowadays. Really, I don't want to even comment on it. Coming back to the main objective, guys, types of respiratory failure is what I have explained to you. Patients who have undergone coronary artery bypass grafting, they suffer from respiratory failure. That's a post-operative atelectasis that will happen, and that was a recent question. In fact, the most important question of this slide is what I have just currently explained to you. Then also remember regarding alveolar arterial gradient, A minus A gradient. Normal alveolar arterial gradient for a person would be 5 to 15 millimeters of mercury. This alveolar arterial gradient would be increased in those conditions where the small a will be reduced. Like suppose if this is A minus A and the value let's take a value of 10 average. If mathematically the small a will reduce, that means the fact that this value, the mathematical value, will become more than 10. Maths, right? Don't get too much into it. If small a will reduce, value will become more than 10. How this a will reduce? This is alveoli. This is the small blood vessel where pressure of A is being taken, and I am saying that if there is a fibrosis in this area, then due to the fibrosis present in interstitial lung disease, the diffusion of gas at area number A will reduce. So air coming in the alveoli will be normal because conducting airways are fine, but there is a interstitial fibrosis in the patient, so small a will reduce. So alveolar arterial gradient is increased in patients having interstitial lung disease, or you can take this to be PUS, interstitial pneumonia. Pneumocystis jirovecii pneumonia, PCP, pneumocystis jirovecii pneumonia, or pneumocystis carinii is the old name, so I'll write pneumocystis jirovecii. I read carinii actually. Pneumocystis jirovecii is gonna cause interstitial pneumonia, or interstitial lung diseases will be having an increase in the gradient. Now I'm gonna symbolically show that the large airways are gonna be connected to the alveoli of the patient. If the main airways are itself blocked, what I'm saying now is, suppose these are the conducting airways, they bring the gas into the alveoli. I'll put a capital A, and then the gas has to diffuse like this from the alveoli into the small blood vessel. What I'm saying is that if there is an obstruction present here, like for example, if I symbolically show extreme bronchospasm, If, for example, I show Cushman spirals blocking the airway here, then you can see that in this condition, there would hardly be any air able to go via the conducting airways. If air cannot go inside, then capital A value will also reduce and small a value will also reduce by the same mathematical proportion. Why? Because gas is not going inside. If capital A and small a both will reduce, then the mathematical value will remain the same. Therefore, in patients who are having airway blockage, that is type 2 respiratory failure, because type 2 failure will be having complete occlusion of airways and carbon dioxide will begin to build up in all examples of type 2 failure, because like status systematicus is what I've shown here. Status systematicus is an example of type 2 failure. Therefore, in the patient, because air is not going inside, there would be a normal alveolar arterial gradient. A minus A gradient will be normal in all examples of type 2, whereas it would be increased in type 1. Let's just revise the data that we have learned. When it comes to type 1 respiratory failure in a patient, the findings are decrease of PO2 less than 60, PCO2 is less than 35, and A minus A gradient, that is alveolar arterial gradient, is increased in the patient because of the fact that the small a is reduced in the patient. But when it comes to type 2 respiratory failure, you will be having obviously a deficiency of oxygen, but there will be a buildup of carbon dioxide in the body of the patient, and in this condition normal alveolar arterial gradient is noticed because the air is not going to go in the conducting airways itself. So capital A and small a both will be reduced in the patient. So these are two comparisons which I want you to remember for type 1 and type 2 respiratory failure respectively. Examples of type 1 respiratory failure will always be resulting in respiratory alkalosis, and examples of type 2 respiratory failure will result in respiratory acidosis in a patient. Highlight of respiratory acidosis will be buildup of carbon dioxide in the body. So more carbon dioxide will produce more protons. We'll study the ABG component or revision of that subsequently, but at the moment I want you to remember these two slides, especially for alveolar arterial gradient and for especially alveolar arterial gradient with respect to respiratory failure in a patient. And there are total of 4 varieties of respiratory failure that I want you to remember from this particular discussion. With especially post-ABG patient, they can be having this post-operative respiratory distress, and chest physiotherapy is the management for the same.